So it looks like we have a quorum, right, Isabel?
That's right.
Okay, all right. Hi, everybody. Welcome to the January Finance and Revenue Committee meeting of the Universal Health Plan Governance Board. Good to see all of you. Happy New Year. Hope you had some restorative time over the holidays and didn't get the viruses that have been circulating. It looks like Jeff has a question. Go ahead.
I appreciate being promoted to the governance board, but the last time I checked, we're still the Finance and Revenue Committee.
I did say the Finance and Revenue Committee of the Universal Health Plan Governance Board.
Oh,
So, thanks.
good.
All right, so with that, let's go to roll call.
Yes, thank you. Cheryl Ramirez.
Here.
Chunwei Chi is absent. Mary Lou Henrich.
Here.
Thank you. Richard Gibson.
Here.
Thank you. John Santa.
Here.
Thank you. Jeff Goodman.
Here?
Thank you. Bethany Stairs. Don't see Bethany yet. Charlie Swanson.
Here.
Thank you. That's everyone.
Thanks.
And Bethany will not be able to make it today.
Okay,
Thanks.
thanks for letting us know. So let's review the agenda really quick and then just get into it. So Mimi, Executive Director, is going to go through board and committee updates and some follow-up from our previous meeting. We have a guest talking to us about medical practice administrative costs. And then Milliman will present on total cost of care estimates. I'm sure you've seen those slides, and then they're going to go through those. We'll go through our revenue plan and the impact on individuals and businesses. That will be Echo Northwest, and I imagine Charlie will be part of that discussion. And then, as usual, meeting reflections, next meeting topics. And we do have one public comment today. John.
I'm sorry, I did not see any slides that had cost of care estimates. Did I miss something? I looked at everything last night and I did not see any slides on cost of care. I mean, other committee members, did anybody see those slides? Am I just missing this, or what's going on?
I saw some slides from Milliman.
Yeah,
So.
I did too.
No, I saw some slides from Milliman around their actuarial work. Cost of care is different.
Okay, does anyone want to talk about the semantics here of the title? Maybe we got the title wrong. I don't know.
Oh, okay, if that's, I'm sorry.
It was just an updating of the total amount that care would cost in 2032 from multiple different vantage points. That's what it was. Is going from 2022 to 2032, also from 2030 to 2030. It was all about 2032 total cost of care, Medicare, non-Medicare, and the total together. A low estimate, high estimate, and a best estimate. That's all.
Okay, I mean, sorry for my confusion. I saw that as Milliman delivering the actuarial information that we need. And I mean, Richard, as you know, the phrase cost of care is very different from actuarial estimates. And that's what's confusing me. And later on in the meeting, I will share with you some reasons for that. But I'll leave that for a later discussion.
Okay, thanks, John. I'm going to hand it over to Mimi now for the board and committee updates and follow-up. Thanks.
Hey, thank you. Good morning, everyone. This is Mimi McDonald, Executive Director of the Universal Health Plan Governance Board. I'm going to start off with follow-up from our previous meeting. So first off, there was a request to have an evaluation like that of other populations for the Medicare population, and there is included an analysis of the proposed tax structure on the Medicare population in comparison to other populations with an excellent paper by Charlie Swanson and also a detailed spreadsheet. Thank you so much, Charlie. Next, there was a question about dissenting opinions. If, for example, committee members don't agree with what is the final opinion that is passed along to the board. And certainly dissenting opinions can always be included in the report, both in the report up to the board and potentially in the final report. I don't want to make any statements regarding that, but certainly if there's a significant rationale behind it, those could certainly be considered for inclusion in the report, as some of them were in the, as you may remember from the Joint Task Force report. Mary Lou.
My question is, when you say report to the board, do you mean the report to the legislature?
No, I mean
What?
reporting from the Finance and Revenue Committee to the board. This is the
Okay.
proposal from the Finance and Revenue Committee to the
I see.
board, and
Okay.
then the report to the legislature.
Okay,
Yes.
just clarity. Thank you.
Mhm, absolutely. All right. Next, coordination with plan design and expenditure. So we've discussed this a couple of times, and it was decided that a joint meeting of Plan Design and Expenditure Committee with the Finance and Revenue Committee would not necessarily be beneficial in terms of the being able to exchange information and be able to facilitate decision making. However, information is certainly being shared back and forth between the committees. For example, so the Plan Design and Expenditure Committee has created their initial benefit package. Milliman has created a cost estimate, an actuarial cost estimate. This committee will be reviewing that estimate today, along with potential revisions of the benefit package that were evaluated at the request of the Plan Design and Expenditure Committee. Of course, the final decision making of the level of benefits and revenue plan rests with the board and will occur during all of the public board meetings. So there does continue to be this as we've talked about multiple times, iterative process between what the benefit plan will be and, of course, the plan for revenue plan. John Santa.
Yeah, this is the issue, actually, I wanted to bring up. I went to the Plan Design Committee website and looked at their documents on Thursday. And they're making a specialty recommendation. And I was surprised to see on page 1 of that specialty recommendation, in a section labeled focus of the recommendation, the first sentence was evaluate benefit plan and provider reimbursement plan relative to cost targets outlined by Finance and Revenue. So they're actually making a key decision with the impression that we have had a substantive discussion and approved what I now learn is the Milliman quote cost target report. And despite being promised multiple times that we'd have the opportunity to meet with other committees, including the Benefit Design Committee, we now hear we're not. So we're being asked to make a key decision with virtually no notice. We got this slide deck last night, and I hope we have a robust discussion of it. Especially since it appears in the report that a major cost target is the Medicare population, and the solution to that is to just get rid of them. I hate to start these meetings out with these kinds of issues, but the process here is flawed, and honestly, I'm losing confidence in it. I'm losing confidence in it. And, I don't want to be that guy that says, I won't take it anymore, but I'm getting there. So just to let members of the committee know, there's already this document at Plan Design that's already been assumed that we'll have a recommendation around, quote, cost targets, and that they will then make decisions on this based on our recommendation. And frankly, I think there's a lot of cost issues outside of the Milliman report that aren't even addressed in the Milliman report. So just a heads up here.
Thank you, John. Charlie.
I would like to second quite a bit of what John said, including the notion that this is the first time we've seen anything from Milliman. And so we have not even begun to consider whatsoever anything related to, I guess, what the cost target is in there, in the report. So everything we've done so far has been based upon optimist estimates. And so, which I can't yet tell if they're extraordinarily different from what Milliman is estimating. And so we'll talk a whole lot more about the Milliman slides, but from what I can tell, there is no information about how they got any of these numbers. It's just, here's some numbers. Well, from where, how, why? Show your work. And then there's no comparison to the status quo. There's no comparison to what Optimus said. So we have no idea how to judge the credibility of any of that. And I'll have a lot more to say about it when we get into the slide deck from Milliman. So thanks.
I just wanted to jump in that Milliman is presenting today, and you'll have the opportunity to ask them questions and comment.
Yeah. But what I'm getting at is everything we've done so far has nothing to do with what Milliman is presenting. And supposedly we're going to come up with something to respond to that. I mean, I don't think that's possible. So
if I may interject, thank you, Charlie, and I certainly understand that. This is certainly, you are absolutely correct. This is the first time sort of that big overview is being presented to this committee, because this is the first time that it's being available to present to this committee. I don't think that I think that's why there's this long discussion period that we have kind of in the second half of the meeting for all of these topics to be brought up and to be put forth in a further discussion. So I think that there's clearly recognition that that information is new. I don't think there's any anticipation that things will be resolved today. Thank you. Jeff.
I concur with what John has said. I concur with what Charlie has. I disagree with not having a plan design and our committee meeting together. We are the two most knowledgeable committees on the revenue side and the expense side. And I am skeptical of the governance board's ability to have the in-depth discussion to reconcile those differences as opposed to simply accepting what the staff puts together without the combined input of the two committees on the revenue and expense side working through these details.
Thank you. Mary Lou.
Mary Lou,
you're on mute if you're speaking.
I'm sorry. I said I agree with what's been said so far, but trying to think a little bit down the road in terms of what are we going to do, and how to try to rectify some of this if we can't have a joint meeting, which I still am in favor of having one, but at least it looks like we need to talk about next meetings and whether we need another meeting this month. I mean, the time is flying, and what's happening, it feels like, is this, rush to the finish, and kind of like, okay, we hear this and don't have time to really think through process, etc., and are asked for a recommendation. And then, I, as a board member, have to sit there at the board meeting, concerned that this kind of in-depth stuff, if I'm struggling with it as a member of this committee, if I weren't part of this, it would be very hard if I were on the communications or on one of the other committees. So I'm thinking we probably need to talk about another meeting before our next regular one. That's all.
Charlie.
So I would also say that from what I can gather, there's been rumors that this committee will not continue for very much longer. And it seems like we may be sort of just starting the work that needs to be done, because we're just getting some estimates of some of the costs, and we have to respond to that. So it's like, I would recommend that we absolutely need to continue meeting for quite some time in order to deal with the questions that are going to come up, because they seem to be like, okay, we're pretty much starting over.
Thank you. All right, well, that leads me into my next point, which is the Finance and Revenue Committee wrap up. So currently, the plan, and this is based with the chairs and the board chairs, that Plan, Design and Expenditure, Operations, and Finance and Revenue Committee will all have their final meetings in March. There is a significant amount of time that will be given to the board, at which the board level decisions will be made in the months of March, April, May, June, and July for all of this discussion and for further evaluation. So the other component to that is that a transition committee will also be starting up in March. The Community Engagement and Communication Committee meetings will resume in March. And then lastly, the other point that was brought up about reserve funding and what are requirements related to the CCOs. Lee Hastings will be presenting on surplus and reserve funds as relate to CCOs. Okay, next slide. All right, thank you. So at the last board meeting, the board had a discussion about a multi-year transition timeline and ended up approving using the calendar year 2032 sort of as an anchor date for which to make financial, that the financial estimates would use that year. Some of that is related to the legislative calendar and the thought about when legislation can be passed and things can be implemented. Some of it is related to the potential for getting federal waivers. As you know, under the current administration, no federal waivers are being evaluated or changed. So that was at the board meeting. There was also a discussion sort of on what I'm describing as regional boundaries. So in other words, actually the footprint of the regions. Again, I just want to iterate again, not service areas. So in other words, there is no, people can get care throughout all of Oregon. Just the regional boundary determination really is related to some other issues and sort of more local evaluation. And then the board is planning at least an hour for revenue discussion in January. And I see John Santa has his hand.
You're
Mute,
muted,
John.
John.
Just a quick reminder, it was months ago, maybe a year ago, that we really had the last substantive discussion here of administrative costs. And the board changed its estimate to a very modest point of view. Today is the first time really we're having an introductory discussion that I think is going to be substantive. First time. And I can go back and look at those meetings, but I think we were also promised that we would have a joint meeting with operations around administrative costs. I've been in a lot of startups and big insurance company administrative structures, and never ever is there a discussion around administrative costs where the financial people aren't involved. Never ever, never ever. In any company, to exclude the financial folks from a discussion of administrative costs is organizational malpractice. And you know, I'm going to hold you all to that promise in terms of finance and revenue getting together with operations after we have had a chance to hopefully get grounded by Jill's comments, and you know, another robust discussion that should ensue. So I just want to put that on the table. That was a promise.
Thank you, John. All right, so in terms of operations, as mentioned, the operations committee did review an estimate from Milliman, or rather a proposal that was put forth by Milliman, and then not by Milliman, but structure that was recommended by Milliman, and then approved by the operation committee of a potential administrative structure, which was then also brought forth to the board. There were cost estimates. I want to be specific about the administrative structure and cost estimates. Those were on the plan side and not estimates on the provider side. We're really lucky today to have Jill Arena, who's going to speak to some of the provider side cost estimates, or rather provider side administrative cost challenges and things that might be changed with a universal health plan. The operations committee also talked about enrollment, again, put forth a proposal about regional boundary determination, and had a discussion regarding the transition committee. Yes, Charlie.
So I want to bring up again the idea that supposedly we're going to have a proposal for a tax plan or for revenue, and we have, as John just mentioned, we have not yet even begun to consider a number of things. Among them, the revenue needed for transition and reserve, transition costs and reserve buildup, et cetera. This is the first time we're actually delving into provider side administrative costs, which are necessary estimates in order to be able to figure out anything about how much
Revenue is needed.
how much the plan will cost, and therefore how much revenue is needed. So it's like, this is just the beginning of it, and all of a sudden we're supposed to by next month have a final recommendation. It's just not possible. It's just not possible.
Thank you. All right, plan design and expenditure, Milliman, and thank you, John, for the nomenclature. I appreciate that for the update. We should not be calling it a cost estimate, but rather an actuarial estimate. So thank you for that. There is also a proposal, none of that has been voted upon, but about how specialty care payments might be made. And also just, I'm sorry, it's not actually a discussion around cost containment. The slide's a little bit old. The discussion will be, there'll be a prescription drug primer, and then also a discussion about behavioral health payment strategies. And then lastly, for community engagement and communications, engagement meeting preparations will be starting. Our consultant is out for the first 2 weeks of January, but then that will be coming up. There will be an updated CECC meeting in January, and then meetings will resume in March. And next, I'm going to turn it over to my colleague, Lee Hastings, who's going to talk about surplus and reserves and CCO financing.
Great, thank you so much. All right, let's dive right in here. So this is in response to a query that was received a while ago regarding CCO surplus and reserves, and whether how that could be used in the financing of a universal health plan. So first, let's start with some definitions, because I think it's really important to keep these in mind. Reserves refer to funds that are held by an organization to pay for current liabilities. So when we are talking about surplus and reserves, reserves are actually not funds that are available. They are funds that are essentially already spoken for, intended to pay for things that are going to come due in the future. Surplus, on the other hand, this will be the focus of our discussion. These are amounts that are not tied to existing liabilities, but available for different kinds of flexible purposes, such as reinvestment or future utilization, etc. Next slide. Now, when we're talking specifically about CCOs, they of course do have some requirements, as all health insurers do. Under Oregon law, they have to meet certain minimum reserve and capital surplus requirements. These are in order to ensure that they are financially stable and therefore able to continue supporting members, etc. So you can see those amounts. They're required to maintain restricted reserves, as well a flat amount of 250,000, as well as additional amounts equal to 50% of those actual and projected liabilities. When it comes to surplus, there's a base amount of 2.5 million plus additional amounts as required. I know that's vague. It's a very complicated formula that is set by the Department of Financial Regulation. Now, notably, CCOs do need to have these capital and surplus amounts on hand to enter into a contract. So these are not funds that are received. I will answer all questions at the end of these slides. Next slide, please. When it comes to CCO surplus limitations, there are a couple. So first and foremost, CCOs have to spend at least 85% of their revenue on medical claims. This is known as the medical loss ratio, or MLR. I can tell you from the latest data available, our CCOs average 89%. So all of them are pretty solidly above this amount. Additionally, in 2018, the Oregon legislature passed what's known as the SHARE program, which requires that after meeting minimum financial standards, CCOs reinvest some portion of the excess or of those surplus back into the community. So this is essentially mandated reinvestment of a certain amount of that surplus. Next slide. And now to really answer the question, where do those surpluses go in the end? Essentially, if an organization were to dissolve, in this case, a CCO, the first order, of course, is managing any outstanding debts and obligations, so paying off those final liabilities. Leftover assets tend to be distributed based on bylaws and then any kind of contractual language. We know from experience, Family Care, when they left the program, were able to take those funds with them, which suggests to us, I did take a look, was not able to find contract language publicly available, but strongly suggests there is no contract language that addresses this. The sort of reality of the situation is that in America, healthcare is business, and therefore surpluses are treated the same as they would be for any other business. So the memo contains a little bit more information, but the conclusion being extremely unlikely any surplus amounts would be reclaimed, especially given that many of our CCOs are part of larger organizations. So those could easily be reinvested in other portions of the organizations. So that is that question. I do see a hand up if you'd like to speak, Charlie.
So I've got two questions, well, a question and a comment. The first question is related to the slide on which you talked about the restricted reserves. If we can go back to that one. So it says 50% of the CCO's total actual or projected liabilities above 250,000. So for what time period are those projected liabilities? So, what is it, for like a month of liabilities, projected liabilities, for a year? So to me, that doesn't mean anything. Like, projected liabilities over what time period? Do you know that?
I don't know offhand. I can tell you that 90 days is pretty standard. So if I had to venture a guess, I'd say 90 days. But I would have to go check the regulation for that. And I'm happy to do so if you'd like.
Okay. And then the other comment is that one of the things that was put forward, I think, in the interim report to the legislature was interim steps or next steps, or steps that could be taken prior to the implementation of a universal healthcare system. And to me, this suggests that one of the steps that should be taken prior to that is regulation of the CCOs and the surplus of the CCOs. And I would say similar in nature to what was once proposed by Representative Mitch Greenlick for CCOs, to hold some money in escrow for the CCOs, so that something like Family Care walking away with all that money cannot occur. So to me, it seems like it would be worthwhile for our committee and the board as a whole to consider suggesting that's some sort of a next step that changes what's going on here, so that there is a way to get at that money for the universal healthcare system when something happens. So I would say that that is something that among the next steps that we can think of doing is a really important and useful one. So, I'll stop there.
Lee, my question was on the same bullet point that Charlie asked about, which is projected liabilities above 250,000. In this particular phrase, does liability mean a single high cost case that's above 250,000? Because I mean, if you're an insurance company and you're insuring 100,000 people, I mean, your liabilities are going to be in the tens of millions, not 250. So I'm thinking that liability here means a given case that's over 250. Is that correct, or am I reading that correctly?
My read is that this applies to liability, so all healthcare costs, not simply those outlier cases. And again, if more specificity is wanted on this definition, I'm happy to really go into the regulation and nail that down.
But if you cease operations, well, let's say at the end of the month, you have all these claims outstanding that won't be paid for 30, 60, 90, 120 days. I mean, again, they're going to be in the tens of millions of dollars. I don't understand why it says above 250,000, but I'll let you wait and come back. That didn't make, I
Yeah.
could put that together.
Insurance
Thank you.
companies do hold quite a large
Oh,
amount
sure.
on reserve. And so, you know, we're talking, assuming the 90 days is correct, 50% of that, we're looking about, yeah, an eighth of what they would spend annually potentially. And based on my knowledge,
Okay.
that's reasonable. But I'll do the double check on the
Thank you.
regulations. Let's see, I'm not sure who was next, whether it was John or Jeff. You two want to hash it out?
I think John was first.
Yeah.
Okay.
Lee, is this your last slide?
Not this one, but the last one that I ended on with the how do reserves resolve?
Okay. Well, I mean, let me just compliment you on this work and on your paper.
Thank you.
I think it was very solid work. I wish the rest of the industry would use the terms reserves and surpluses consistent with your definitions.
Yeah.
You know, during the Care Oregon transaction, the word reserves were commonly used by Care Oregon to describe their $1.3 billion in quote reserves, and they even use that term, I believe, in their annual report. But it is important that there is this distinction between reserves and surpluses. I do think we should have a bit of a brainstorming discussion at some point when time allows on what are the options going forward in terms of both reserves and surplus. Will it require legislation and changing the law? Yes. Yes, I would agree with your current sense of how things work. I would remind everybody, for those of us around when family care left the CCO market, I'm sure I read hundreds, if not thousands of pages from family care claiming that they were on the verge of bankruptcy. Because of OHA's terrible deeds, and Care Oregon, they attacked Care Oregon multiple times, and then when they do exit the market, they have funds remaining for a very substantial foundation, which they've done good things with. I would also remind you that in another state, Washington, when Group Health of Washington decided that their financial future was problematic and they needed to merge with Kaiser Northwest, they also reported that they were on the verge of bankruptcy. When it all actually happened, as a result of that merger, $1 billion corporation, organization, foundation was founded, $1 billion. So the estimates in terms of their solvency were, just $1 billion off. So this is a big topic. I believe, for example, that it would be appropriate, if not good practice, for the laws when it comes to Medicaid reserves to be changed such that those reserves must also reflect some of the unique contributions that are occurring or supposedly are occurring in CCOs. For example, we have a $1 billion waiver around social determinants. Much of that $1 billion is going through CCOs.
I'm
Whatever's
sorry,
left of
John,
that $1 billion.
I apologize for interrupting. Our guest was supposed to start speaking at 9:15, so I'm asking if you all could.
My apologies.
That's
But
all right.
you know, I also would just end by bringing attention to Milliman appropriately uses a term they call induced demand. And, you know, induced demand is certainly a reasonable one to use when you're talking about uninsured people who are now insured. But in the case of CCOs, where there's been questions about primary care performance, their ability to provide access, their strong degree of variation in terms of performance, I would argue and will argue when it comes to that part of the discussion that a portion of any induced demand should come from CCO reserves as it relates to the Medicaid population to cover the care that they were supposed to provide and failed to do so. And yes, that would require a law, and it would require an actuary making an estimate of that. So more to come.
Thank you. Jeff and Charlie, I'm going to ask, if you don't mind, if you could hold on to your thoughts about this. We'll have a moment, but I really would like to introduce our guest speaker, who is slated for 9:15, and I appreciate her time. So, and then we can definitely, so please hold on to those thoughts and we will get back to it. So if we can just go on to the next slide. So it is my absolute pleasure to introduce Ms. Jill Arena. Ms. Arena is the CEO of Health ePractices LLC and leads its operations. She is a nationally recognized expert in medical practice finance and operations, as well as revenue cycle management and leadership development. She is a serial entrepreneur, which I think is a very interesting title. She's co-founded several different entities, frequent speaker and convener in the medical community. In a career spanning more than 30 years, Ms. Arena has guided the launch of more than 90 new medical clinics in multiple states. And during her work with Health ePractices, she served several medical groups in interim leadership positions as CEO and administrator. So again, thank you so much. She's generously giving of her time here to the Universal Health Plan Governance Board. So I'll turn it over to you, Ms. Arena.
Thank you very much. Thank you for the kind introduction as well. Am I able to share slides? Oh, perfect. Let me see if I can do that. If I click all the right buttons here, we'll have ourselves a slideshow. It is delightful to be with all of you this morning. The request I got was to talk a little bit about, from the provider perspective, what a move for outpatient medicine would look like to universal health. And I have some thoughts for you about administrative costs that are woven in there. And let me see if I can put us in slideshow mode. I also have far more slides than I should for a 30-minute talk, so I would ask you give me the hook when you need to. I know you've got a long agenda, so I want to respect that. And also would ask that you interrupt me as we're going along. I'd much rather this be a dialogue. So I'm going to move pretty quickly because we have a lot of thoughts to share. So first of all, thank you all for the work that you're doing and the clear thought and care that is going into this. I appreciate just hearing the conversation this morning. So it's wonderful that we have so many fine minds thinking about this. When I think about a big question like this, my tendency is to sort of organize thinking a bit the way the Medical Group Management Association does in terms of domains of practice. So when we think about medical practices, and I should be clear, the vast majority of my experience the last many years is private practice, although I have spent a fair bit of time running clinics in an integrated delivery network at Providence, and also have done a fair bit of work within the FQHC structure and also the IHS structure too. So most of my comments are stemming from private practice as a lens, but all of what I have to say will apply to any outpatient clinic setting. So when we think about the impact on these 5 domains, I looked at this, obviously with operations management, we're going to have a lot of simplification in the billing and the revenue cycle side. We'll also have very likely increased patient demand, and that will create some fairly significant shifts in staffing if we're to right staff after this transition, so after 2032. On the financial management side, I believe we will benefit, or practices will benefit from a higher degree of predictability with the revenue for certain. There will be some margin implications, and I have lots more questions about that for all of you to ponder. And then as we want to talk about the cost structure today as well. Thinking a little bit from the human resources lens, we're going to need to be thinking about our workforce. Lots of questions about that. How do we redeploy folks? There will be a fairly significant shift in who is needed where in the outpatient side of the world. Morale improvements, with big change, that's a little tough to manage. I always like to say this all would be a lot easier if it weren't for the people. But that's one of the things we'll have to consider. And then obviously training needs if we're making a big shift with the workforce, what that looks like. From a risk and compliance perspective, I believe there's a lot to be had here in terms of simplification in the compliance landscape for the practices. I see lots of nodding. Obviously, a lot of simplification with payer dependency and utilization management. Charlie, you have a question or a comment?
Yeah, so my question is related to sort of an overall, how large of a segment of the healthcare expenditures is this piece of private practice that's not connected with a larger hospital system of some kind?
Ooh, good question.
Just roughly, I guess, sort of what fraction of expenditures, perhaps?
Yeah, it's an excellent question. When we talk broadly about, sort of where do the healthcare dollars go, on a nationwide basis, we can see, maybe 11 to 12% primary care, and my numbers are a little bit old, so I don't want to call on that. If you divide that in terms of, how much primary care is private practice versus health system, obviously the private practice number is shrinking dramatically. We don't see too many private practice primary care groups surviving. There are the exceptions, but like in the Portland market, we've got Northwest Primary Care as a big exception, a standalone primary care. If you wanted to take a look at that snapshot from an outpatient perspective, thinking primary care and subspecialty together, that's a bigger number. Obviously, the subspecialists are still largely independent of the health systems, with some subspecialty variation in that. So I can find you a number, Charlie. I wouldn't have one off the top of my head that I would feel really confident with.
Great. That would be wonderful if you could find a
Okay.
number.
I'll make a note on that. And Mary Lou. good morning.
Just wondering where in these different buckets is the cost of IT live?
Yeah, that would be under operations management. And I do have some thoughts about that. It's an interesting
Okay.
question to think about, with the
future.
average outpatient IT spend, how a change like this would impact that.
Thank you.
Yeah, you
Okay.
bet. All right. So I think we were talking about simplified compliance for certain, and a change in also a reduction or a huge increase, depending on how you look at it, payer dependency, right? So we work with a lot of practices that we help them focus on their payer mix because they have an unhealthy payer dependency in some way, shape, or form. So, and then lastly, strategic planning. I probably won't spend a lot of time talking about that today, as we're wanting to focus more on administrative costs, but that's a consideration we'd want to have. All right. So as I think about this again, looking through that operational lens to start with, what decreases? So revenue cycle, as we've said, becomes dramatically simpler. Billing to one public payer and eliminating the patient portion of that. We've seen the patient portion of outpatient medicine shift from 20-ish% a decade ago to a lot closer to 25% today, with just the rise of the high deductible plans and a lot of people just simply choosing to be, cash pay or uninsured. So that eliminating that is a big part of my administrative cost estimate, which you'll see in a couple of slides from now. But that is going to be a big shift in terms of the cost on the revenue cycle side for practices. The administrative staffing needs for billing and collections and follow-up and bad debt accounting will drop very dramatically, and that will reduce overhead and it'll reduce a lot of complexity. I think one of the challenges for a group like this, as you think about how do we talk about this with physicians and how do we sell this to physicians, and I'm going to say this gently and with a lot of love in my heart for all of my physician friends and colleagues, most of them don't really understand the revenue cycle. One of the pieces of learning that we've had in the Physician Leadership Project as faculty there for the last 6 years, when we close the door and we start to break down the financial underpinnings of the medical practice, most of the physicians don't really have a basic understanding of the resource-based relative value system. They don't understand RVUs. If they're compensated based on RVUs or work RVUs, they have a slightly better understanding. But all of that to say, again, I'm saying this gently and with love, we have an audience of people who are going to have a huge simplification, and they're not going to understand that. They're not going to understand why that's important to them or really how that will save them money unless we really break it down to the simplest terms. So, and again, I say that with a lot of love and respect. We don't teach business in medical school anywhere yet in this country. I think I'm going to take that on as my hobby when I retire. But we really don't. We have an audience that is sort of unaware of what the business underpinnings are of the things that they own and operate. So that will be a challenge in making this shift, is all the administrative cost savings that I can talk to you about are going to be difficult to explain to the people who are going to benefit from them. So I'll get off that soapbox, but what increases? I think the thing that probably your group could predict better than I could is what will be the demand surge when we suddenly have a group of patients who have access to care who have not in the past. What's the unmet need out there? What are the undiagnosed issues that the patient population is walking around with? And how much will that shift what happens in the outpatient side of the world in terms of new patients showing up that perhaps haven't had care or haven't had much care in the past. So thinking about it from a macro perspective and a community perspective, how big is that tsunami that's coming at us? We've got, outpatient practices are going to need to scale scheduling, intake capacity, clinical staffing, all of it. And potentially that'll require extending hours and or opening additional space, or potentially we'll see a shift in which spaces can be reutilized for different purposes. So, Charlie, please.
I would also add that there's going to be history of these kinds of things happening before would show there's going to be a prioritization change, that those who did not get care before will all of a sudden get a lot more care. Those who have gotten a lot of care in the status quo will get a little bit less care. I mean, that's what's always happened. That's what happened when with the ACA expansion of Medicaid. That's what happened with the introduction of Medicare. That's what's happened in other countries. So
Yeah.
It's really hard to estimate what that, I guess, sort of induced demand will be,
Mhm.
but history would show it's not very much because of the prioritization.
Yeah. That's a great point. I love it. I am excited about the opportunity for people who have been a bit marginalized in the system to get better care under the model. So that's what has me thinking hard about this. Mary Lou.
I guess I'm just thinking that we really had this quote, problem or issue facing us in 94 when we started the expansion of the Oregon Health Plan. And then incrementally, as we have moved the income level up to now in Oregon 200%, you know, I really do believe that the poorest and marginalized folks really have had much more access in the last, you know, 10, 15 years. And so in my mind, people who haven't been insured, you know, there is the group that's kind of right above that, you know, people who make just a little too much, and there's that group. But then there's quite a group of people that I happen to run into or know that just have chosen not to be insured because of the cost of it, and really haven't used the health system and really don't desire to use it or don't seem to need to use it. I mean, there's a lot of kind of healthy, you know, folks before middle age kind of going, well, you know, I don't need this, and I'm not going to pay for it. So it is a dicey thing to try to ferret it out. I agree with you. I won't.
Yeah.
Okay.
And I appreciate the comment about sort of general attitudes about the use of a healthcare system. That'll be the same before and after too, right? I mean, that's yeah. So we'll have some folks that flat out refuse to go, and some that are going to get their healthcare in alternative ways. And so, yeah, wonderful. So these are thoughts through the sort of the lens of what are the administrative changes we could anticipate. We've talked a bit about billing simplification. We'll come back to that. That's actually where a lot of the cost savings can be had, in my opinion. Time reclaimed, as I was doing research on this, I have a future slide that talks a little bit about physician and clinician time. There was this notion that we're going to reclaim time, definitely in the revenue cycle group, in terms of not working claim denials, resubmissions, partial payments, denied payments, that kind of thing. Presuming that the universal healthcare is easier to bill and there are fewer denials. That's a big assumption. So I want to put that out there. But that should theoretically free up a lot of billing staff capacity and allow them to either be retrained and shifted to another part of the workforce, or, you know, potentially retrained to another industry. And then we've got I think we could think about a fair degree of infrastructure strain, and we would want to plan for that. Again, the question is, you know, how big is the tsunami? And Mary Lou, your point is well made. It may not be as big as it was back in the mid 90s. That was a shift for sure. All right. So a little bit more dialed in on the financial picture now, on the revenue transformation. The research that I could find in thinking about making this move and where others have gone before us showed a 5 to 9% revenue increase. That was sort of the definition of how big is the tsunami, right? So we think it will add another 5 to 9% utilization, maybe. Kind of, sort of. And again, that's anyone's guess. Probably the folks at Milliman are going to do a good job of doing some actuarial crunching for you, it sounds like. This one here I found interesting, but in researching, there was this notion that physicians and clinicians currently spend about 5% of their time on billing related work. So that's a question for this committee is, will the new world have the revenue cycle simplified enough? And there's all kinds of questions about coding and documentation requirements and all of that would feed into this notion of whether or not we could actually realize a 5% time savings. If you could, I mean, there's a fascinating question right there for the entire physician population. If you could realize a 5% time reduction, what would you do with that? You know, would the physicians take a little bit more time off, have a little bit of time to breathe? Would they apply that to the 5 to 9%, you know, increase in demand? Potentially they have the same workday, it's just more patient care, less billing related activities. So a fair number of questions there. And then again, the really exciting part is just that we move the patient balance risk or the financial risk to the physician. For the patient making their payment, there's no more risk on that side. We move that down to 0. So that's actually something I think you could easily explain and sell to the physician community. All right, so cost structure and margin implications when we think about this. Certainly, a shift like this would lower the overhead. So billing and revenue cycle costs would drop significantly. That's going to improve each practice's net margin. What's highlighted there is the big question mark, right? With the reimbursement rates and what happens to those. And I have some numbers coming up for you here. Higher variable costs. So again, if we add 5 to 9% of that tsunami, and that's not like a tsunami, but maybe it's just like a new plateau that we move to, obviously when we increase patient volume, we've got an increase in all of our variable costs on the outpatient side. And then there's the rate pressure, right? So as we look at clinics now where they have sort of the full gamut of the payers, if the public payer sets reimbursement significantly below commercial rates, and I would say significantly below what the average reimbursement per RVU is for the average practice now, then we're going to see compressed margins. And that is likely to mostly come out of the physician or clinician's pocket. There's not a lot of fat in the average practice right now, so there's not a lot of places to cut. You could certainly cut some of the administrative costs that we'd see come out of billing. There may be some other places to cut. Again, there's a lot of questions in there, but as it stands right now, the average physician practice does not have a lot of margins. So any reduction is going to be a reduction in pay for the clinician owners. Charlie.
So do you have any general information about the typical patient mix, or if that's even a reasonable question, of like what fraction are Medicaid, Medicare, commercial insurance? And so some notion of what fraction of Medicare reimbursement rate would be required to keep physicians whole on average?
Yes, great question. We do look at, through our code mastery program, we do look at a weighted average reimbursement per RVU for clinics. I think that's the question you're getting at, Charlie. Like how much do they actually, yeah. I have that coming up on a slide here. I believe I'm gonna misquote my slide, so I probably shouldn't do that. But
It's okay. We can wait and get the answer when you wait to that slide.
That's a great question. I don't know how many slides it is, and I probably should keep moving, but let me come back to that. We'll put a pin in that question. That's a great one. So I think we've talked through this, and I want to keep us moving here. I did talk a little bit about the workforce impact that we're likely to see, right? We're going to need a lot fewer people in revenue cycle. We're likely to need some more people in the front office. One of the big questions I think we have is around what will happen with referrals and prior authorizations. That's another big administrative question for the practice. So we've talked through most of this too. I think in the interest of time, I want to keep us moving. Mimi, I'll send you the slides, so I hope you'll share those with the group. All right, so a little bit of the care model strategy that I can see in terms of how it would evolve. My hope would be that we would see with this incoming tsunami a preventive care surge, that we would get, again, more people like we saw in the mid-90s, more people coming in for preventive care. We'd have the opportunity to simplify a lot of our payment work, and that we would hopefully then see practices investing in more care coordination, more preventive care infrastructure, more chronic disease management, and a lot more patient outreach. We have a lot of automation tools right now for patient outreach, and my humble opinion, as an industry, we woefully underutilize those. So I hope that there would be some opportunity to utilize the technology a little bit better. These are a few strategic planning imperatives. And again, I don't know that I want to spend a lot of time here this morning in the interest of your schedule and getting to some of the cost estimates that we had. Definitely groups will need scenario modeling, and they will also need to make some capacity projections and decisions, and then think about how they're investing. And then lastly, anytime we're pushing a change this large, communicate. So very quickly, primary care, as I think about a change like this, for primary care, it would position them to really thrive, in my opinion. Lower overhead makes primary care really well suited to benefit from this administrative shift, and from the increased volume. Again, all of this is predicated on that reimbursement rate coming in at a place where it's workable for the practice. The stable revenue base would very much help the average primary care practice. With this kind of a shift, we might even see more private practices in primary care coming back to life, which is an interesting thing to think about. And then obviously the VBR is the big question out there as to, will there be a portion of the revenue that is quality based or value based? And if so, what does that look like? And then the groups that are already successful with those model, my sense is they would be poised to succeed. The big question mark, as I look at the landscape for outpatient medicine, is really with the surgically based or the procedural based practices. I think they would see some more headwinds here. I'll make a rather racy statement that it's probably okay for a shift to occur in the system. Mary Lou knows where I'm going, but perhaps slightly less compensation for the specialty groups and slightly more for primary care. Now I'm showing my primary care colors. That's where I grew up. That's where my heart is. And I think it's probably okay. Please don't tell any of my subspecialty clients that I said that out loud in a meeting. But there's, I think that obviously the rate pressure for them, they would probably feel that more than primary care, just they have larger margins now. So as margins get compressed, I think it makes sense as we're looking at a universal solution that, those things sort of get balanced out a little bit. They may or may not be as impacted by the tsunami that we're talking about. So there's some volume uncertainty. And then I think with the subspecialty practices, if my clients came to me to ask questions about this type of a shift, we'd be talking about a big strategic rethink with them. So at any rate, this is a little bit of a breakdown as we think about the difference between primary care and procedural care. And again, I think in the interest of time, we won't spend a lot of time here, but I'll share these slides and happy to take questions from anybody on the committee after the fact as well. This is also a little bit more of just this, how would things flow? And I think you all have a very good sense of how the change would be managed. Mary Lou.
I guess one of my questions isn't totally about what we're talking about doing, but just kind of, have you been thinking about and trying to figure out savings or ways that things could be done better with AI and with IT and having more telemedicine versus I mean, there's just so many factors besides what we're upsetting the whole thing, but all these other pieces on top of it. So I don't know.
That's a great question. Whole nother bailiwick. We probably need a whole other slideshow.
Yes. So anyway, it's just tinkling around in my head. I keep thinking about what will healthcare and medicine really look like from some of these things that are totally outside of our purview at the moment. Anyway, that's
absolutely. No, great question. And to follow up on my earlier conversation about, we have a boatload of technology that's available to us, and we really, on the outpatient side at any rate, and I would say both for health systems and for private practices, we are woefully underutilizing what's out there and available. I spend a few hours every week in an AI course to try to keep myself fresh, and it's a multidisciplinary, so it's not just healthcare people, it's all industries. And we also routinely vet software vendors that have AI solutions out there for practices. And so I get to see, I'm kind of a technology geek. I like to have the latest new gizmo. So I like for our clients to know what's out there too. So there is some very exciting things coming out with AI and RPA both, especially on the administrative side. We have a lot of repetitive tasks that lend themselves very well to, a technology solution of some kind rather than a human solution. We see a lot of those being kind of that Pareto principle, right? The 80-20, we can deal with 80% of the prior auths with an AI agent rather than, a human in the practice. So all of those are out there. There are quite a few of them are fairly functional. Some of them are a little more than beta tested. So it's a little, Richard and I have lived enough beta testing over our years at Providence that a lot of gray hair are involved there too. But I think you ask an excellent question. And I think that for whatever reason, I've never been able to quite figure it out. I can observe it though over the last many decades. Healthcare, especially outpatient medicine, is probably a decade or two behind in terms of use of technology. In the years that I was at Greenfield, we would always talk about Amazon Easy, and Amazon wasn't even that easy back then, you know. And so, that I can hit my phone 3 times and have something that I need land on my doorstep. It's like, why can't we make healthcare that easy? So that's a provocative question. I'd
Yeah.
love to push our clients on a little bit. The fact of the matter is, there's still, even Epic, there still is no one kind of one size fits all technology
Yes.
solution to roll out into an outpatient practice. But I think that the more sophisticated groups we see now using technology are being very mindful and thoughtful about what are the technology components that they're pulling into their practice, and really looking at it from a problem-solving perspective of where does the patient experience get bogged down as they're moving through my practice, and how can I solve that with a human solution or a technology solution or some other kind of solution. So
Thank you.
I'd love to talk more about that. That's not what we're here to talk about today, but it's a great
Sorry.
question. No, it's fabulous question. So here's my sort of short list of what practices would need to get there. First off, I'm being a finance person by background. I always start with a financial pro forma. It's like if there's any big change coming down the road, we want to know as best we can what we think is going to happen. Following that, and usually we use the financial pro forma to then jump into what are the operational considerations. So obviously the groups are going to need a lot of operational design and redesign. And then overlooking all of that, I would say, ongoing strategic advisory. And the other thing I'll say is that our clients, we find frequently don't engage in routine strategic planning the way I would see in like a larger health system or a bigger organization. So that's another thing physicians don't ever get taught in medical school, is that it's important to do a long-term strategic plan for your organization. So we frequently are doing that for groups for the first time. And then we try to help them, kind of keep that ongoing so that they have some idea, kind of pick their head up and look at the horizon from time to time. So I want to get into a little bit more. Charlie, this comes back to your question here. Current state, I'm glad I didn't say numbers out loud because I would have misquoted my slide. But this, obviously, currently, our current state with fee-for-service payers, we have a very huge variation in every single practice. We do have a sense, and it widely varies by practice, what the payer mix looks like. I routinely ask that question with our clients. Sometimes it is really challenging to pull that information out of a system. And oddly, the average practice management system does not have a payer mix report in it. So you really have to, I know, Charlie, is it crazy, isn't it? You have to really try to get that data out. And we make all kinds of extrapolation off of, look at an accounts receivable report that's maybe sorted by payer class. And then we, that assumes that the staff is putting the payers in the right bucket too. So there's some big assumptions. But that's, so I would say, we see practices that are anywhere from 5 to 10% Medicare on up to 55% Medicare. And that's when I start talking with physicians about, hey, do you understand how those payers pay you? My team always laughs, but one of my favorite lines is, all patients are created equal, all payers are not. And I say that to physicians, so like, let's just get really clear here about how you get paid by these different payers, and why, as a finance person, when I come in and look at your practice, I'm talking to you about your mix, because you need to be able to pay yourself after you pay for your staff and your med mal insurance and your table paper and your tongue depressors. So that is another thing most practicing physicians don't really get, is, again, back to the basic building blocks of how they get paid, how Medicaid reimburses them, Medicare, and the commercial payers. We go into a lot of practices that have not renegotiated their insurance contracts in many, many years. And of course, we say best practice is once a year, and keep that cadence going. So Charlie, long time to answer your very brief question from earlier, but what we see for fee-for-service revenue, when we sort of just collapse all of it, and we average it, practices, probably at the low, we've probably seen lower than $45 per RVU. And I would say that, and this again is the average of all of Medicare, Medicaid, and commercial. Commercial rates in Portland right now are probably mid 50s and on up per RVU. If you're the Oregon clinic, it's probably a lot higher than that because you have a lot of, negotiating leverage. But if you're a small to medium-sized group, you're probably in the 50 to 65 range per RVU. Is that helpful, and does that answer your question, Charlie?
Um, I guess it sort of does. I need to find out what an RVU is before it really helps me, but
Okay.
I can find that out. But I did have another question on the previous slide. So
Okay, we can go back there. To
Yeah.
maybe connect the dots for you, you ask about a percent of Medicare. So Medicare is paying, I think it's $35 and some change per RVU this year.
okay. Oh, that helps a lot.
So if
Yeah,
that
thank
helps you, 45%, $45, you can do the math on what percent that is.
Right.
But
Okay.
yeah,
So going
Previous
back to
slide,
the previous
yes.
slide. So one of the things this is indicating to me is that the transition process and the state system may well be very well helped by implementing a physician practice helpline, not really helpline, help system that employs people like you to go out and help practices get ready for the transition or make the transition. So and actually have that funded by the state plan to some extent. So to me, it seems like there's something real to think about there that could be considered part of the transition costs.
Yeah, I love it. I hadn't quite gone that far yet in terms of the practicality of it, but I would say at a minimum, sort of the playbook for how a practice could transition, and that's certainly we have playbooks as Mimi said. We've started, I think now we're close to 100 new practices, so we have a long list of what it takes to start a new practice de novo. And I would tend to start with something like that and just say, all right, we have the whole laundry list. What if this is going to be applicable in moving to universal health care? And then how would we create a playbook? What would be our, recommendations for best practices for groups? So absolutely. That's the kind of stuff for me that's fun to think about. I like it. So John, hello. Oh, you're on mute. Oh, John, you're still muted in the Zoom. We can't hear you. It's that darn microphone button. How are you?
Good.
It's great to
And
see you.
thanks for doing this. You're
Absolutely.
terrific. In follow-up to this discussion with Charlie, I assume that many of the hospitals do have sophisticated folks like you, do have sophisticated financial systems.
Mhm.
They're very aware of their patient mix. They can press a few buttons and see if XYZ strategy is working to change their patient mix.
Yep.
And I believe that about 75% of physician practices are now hospital owned or managed. And you're absolutely right. From a primary care point of view, it's getting
Close to
near
100,
single
yeah.
digit numbers.
Yeah.
Primary care is so vulnerable. But many of your points are also points that should be on the table with hospitals in terms of their administrative costs for their practices.
Yep.
Thank you very much. I'll go back to you.
You and I are going to be in violent agreement on that one. Thank you. Oh, all right. Very good. Well, let me hop back over to the slide. I think this is going to be most helpful. We've got a little bit more thoughts about cost. And Mimi, am I okay for time? Do you need me to wrap it up? So, okay.
Yep, you're good. Thank you.
Thank you. So thinking about this sort of current state and future state, right? We know with the fee-for-service payers right now, our current state is we have a huge variation in that by practice, and each practice is managing relationships with, many, many, many different insurers that they are attempting to bill and collect from. We go into, billing systems, and we're looking at lists that number in the hundreds of insurance plans that are billed by any individual practice. So it's very complex. The future state being one payer, there's a lot of attractiveness to that, right? There's a lot to be said. I think the question I would put to all of you, many of our clients have, a fair bit of their revenue coming from quality initiatives, pay for performance, value-based reimbursement, all the alphabet soup there, right? And we have a lot of variation in those agreements. Again, I think that it would be attractive to have one payer and to have standard agreements if there's going to be, VBR or whatever it is that you're considering as additional compensation that might be quality-based. So Mary Lou, please. Yep, and you're muted in the Zoom still. There you go.
I guess one of my questions before you and brought this slide up and said was about this value-based payment. It's being quite debated hotly in terms of
Yeah.
various folks on various of our committees and the board. Do you have any kind of estimate? We talk about, and I've been managed clinics and I also started Care Oregon. Okay, so I've kind of seen things from both
Yeah.
sides.
Yeah.
But what is do you have an estimate of like the amount of time that ends up being money that is used at the provider end to kind of verify that they really got all of this stuff that's being looked at and questioned and measured? And we know there's time on the payer side, insurer side, whatever, kind of having. I had a staff of people working on this.
Yeah.
But anyways, is that a significant cost or
Yeah. It's a
at the
great
provider side?
Great question. I sort of look at it a little bit as a sort of an on-off switch. When we go in to look at practices, I find two different kinds: those that do quality and those that don't. And I don't mean quality care, lowercase q.
Yeah.
I think everybody does quality care. It's those who really understand the quality programs and who really benefit from those. Sometimes that line pretty well follows size of practice, right? So most small practices do not have the time and bandwidth to even try to wrap their arms around quality initiatives. The larger ones do a better job. I think about the Portland Clinic as an example. They have a chief population health improvement officer. That's the Paige, and she's fabulous. And so there's that investment, right? And the group is large enough and sophisticated enough that they enter into those kinds of contracts. They have sophistication to negotiate those kinds of contracts. So it's a very different answer to your question depending on what side of the world you're on. I do see a few smaller groups, and we have some of them in our client base, that actually do embrace quality and do really well, and less than 20 clinicians in a practice, but they're really maximizing their quality. So that's a commitment from leadership, to figure that out on a smaller scale with fewer tools available to you. But so I definitely would be, it would be possible to try to quantify that, but the answer is going to be different, based on the size, probably.
Yeah, I've seen the good, the bad, and the ugly.
Yeah, I'm sure you
about
have.
all of this, and the
There's
potential gaming on all sides.
Oh, yeah.
How do we document this or that so that we can call it that or this, or so, and everybody trying to develop something that isn't that is truly about quality. But I think that word is quite variable.
Yeah, absolutely. Well, and
Anyway.
it's there's also, there's all the discussion you're pointing to about, is it an outcome measure? Is it a process measure?
I know.
Really helps
Do we
us
measure what's easy to measure because it's easy to measure, and does it really matter or quality? So we won't go down that road.
Yeah, that's another good tangent we could take. We have a lot of good tangents.
I can go on tangents. I'll try.
You can see where I have it right now. This last line here, the quality revenue is, all over the place as far as the different groups and what they're earning. And those that do well, it really differs by the year too, if the health plan is doing well and how much they're able to pass through. So I think in a future state, again, we're thinking about this, more predictability would likely have some of those smaller groups returning a focus to quality and specific quality programs. So I think, again, thinking about this kind of a shift, we could see a heightened interest in quality again. And a little bit back to that notion of, do we have a playbook for how do we get there? And if the quality reporting were made easier, that's another thing I think, oddly, we haven't really applied technology to very well. It's still very clunky in most practices that we go into. Any other questions before I move off of this fee-for-service revenue? Okay. All right. Here's a little bit of the cost savings. So revenue cycle, my current state, you'll see that's a technical term that we use frequently. The future state is going to be a lot less wackadoodle. This is a very, very rough estimate on my part. I want to stress very, very rough. I've been thinking about this, thought we could probably eliminate 20 to 25% of the total cost of collections on the outpatient side of the world, with this kind of shift. So what that means in real numbers is of all the money that comes into a medical practice, currently groups spend 5 to 10% of their money collecting their money. So if it's $100,000, it costs us $5,000 to $10,000 to go get it, right? If that's how much money came in, that probably means we put $150,000 on the books, right? Gross charges, and then we're going to collect $100,000, and it's going to cost us $5,000 to $10,000 to collect that. My estimate, again, rough, is that we could lower those numbers by about a third. And again, that's eliminating the patient collection activity, which, as we said, 20 to 25% of the revenue. Maybe not 20 to 25% of the cost. It may actually be more in some practices. Collecting money from patients is expensive and time consuming, and we don't do it very effectively. So that's a piece I think we could eliminate. I threw in an extra, 10 to 13% to move to a single payer. So that means we're not wrangling with Medicaid, Medicare, VA, workers' comp, blah, blah, blah. So it's possible that there are quite a bit more savings there. But the total number that you're working with is that 5 to 10% of revenue number. So just to be clear, that's what's on the table from a revenue cycle perspective in terms of cost savings. Mary Lou, you'd ask a question about technology, and I want to come back to that. In thinking about this, one of the big expenditures for a practice is obviously paying for their EHR, their practice management system, EDI systems, so the electronic data interface that allows us to push claims, is also another cost that's typically not well understood, again, by physicians, either the setup of the EDI or the cost of it. So I would say currently we're sitting in this fully loaded state, and I would assume, given a change like this, that we might see some potential for reduction in those costs, again, depending upon what the billing and reporting requirements would be from the new organization. So again, very broad statements. Charlie, please.
So it looks like you're counting the time that is saved in a physician's office. What you're looking at cost of collections, but there's other insurance related activities that occur. And some of those require the medical staff to spend time doing them.
Yes.
And
So prior
I'm
auths and
assuming that's
referrals are not even here.
Yeah, I'm
Yeah.
assuming that, well, and just trying to explain why this physician should in fact be reimbursed for serving this patient. And sometimes it requires the physician to actually write down an explanation of that. So So I'm assuming that's sort of a separate savings, just mostly in time that you've accounted it for in that 5% time savings. Is that correct?
Thank you. That's a great question. Great distinction. The 5 to 10% is strictly billing, strictly revenue cycle cost of collections. So that does not consider any potential savings we might have from prior authorization or referral activity, or as you're suggesting, things like peer-to-peer or appeals on claims. And that is all, again, going to be driven by what are the regulations of the new entity and how much would we be able to reduce the burden of referrals and prior authorizations. And that's a big question. That's an operational question for the new entity, but that would drive much, much more cost savings than what I'm showing here, depending on the structure. Yep, absolutely. Fritz, good morning.
Hi, Jill. This is super interesting. I don't want to take a lot of time away from your presentation here, but can you clarify what you mentioned about workman's comp? We're not assuming right now that workman's comp costs are under the UHP. So did you say they would be covered in? Yeah, go ahead. Yeah, that's my question.
Only to say, working with workers' comp and motor vehicle accident is a significant time sink in a revenue cycle department. So if those can be bundled in, more cost savings. If they are excluded from the plan, that would be understandable because it's a totally different animal, but less cost savings there. Does that help?
Yep, very good. Thank
Okay,
you.
you're welcome. Mary Lou.
That got me off onto that tangent, but
Another tangent.
because there has been discussion among some of us about the medical part of workman's comp, and
Mhm.
you know, and really, in my mind, it would make a lot of sense. So anyway, we haven't really gone there a lot. But the part on the if I think what we're talking about is a much simplified prior auth.
Mhm.
And
Mhm.
now, I mean, there'll be some stuff that's going to come up today, I think, with Milliman's slides that we'll be discussing. But I think in our original thinking, it was, you know, not going to be doing this, trying to, you know, have everybody, you know, the prior auth, no, we can't do it. Yes, we can add more money. And the fact, you know, I just think one of the jokes out there in healthcare stuff is that we still use fax machines.
Yep.
You know, that's kind of like who uses a fax machine, only medical care.
Exactly.
But anyway, that piece of savings, I do think really our plan is to structurally reduce that greatly.
Okay. Yeah. And that would be wonderful to look at. That's going to impact your specialty practices most positively. If they do not need to be doing a lot of seeking of prior auth, it's also going to greatly impact your patient experience. I have lots of stories I could tell about prior auth, but those are the prior auth is being fairly successfully automated with AI with those groups that are choosing to go there. So it's becoming slightly less burdensome, but there's still a lot of cost savings that
There's
could be
still a lot
had.
of pharmacy stuff too.
Yeah, yeah, absolutely. Yeah, very good. Marianne or Mary Lou, oh, that was your last question. Okay, John.
Sorry.
Yeah, I just want to say to my colleagues on the committee, I sit here and what Jill is describing really is a negotiation process between two parties who hopefully trust each other. I mean, realize many physician groups have a very low degree of trust currently in at least a subset of payers. But in an environment that stresses collaboration, trust, and transparency, look at all the issues that the payer and the provider could go through and basically say, how about pre-authorization? How can we minimize it? We look at our data and it looks like your group rarely gets out of line in terms of doing inappropriate things. Yeah, and that's one of 50 to 100 topics that you could sit down with a collaborative group and negotiate a relationship with. It's really all there for the taking. It's just whether we can get to it.
Yeah, that's well put, John. I would say prior auths and referrals are one of the largest headaches in outpatient
Yes.
medicine, and the need to appeal claims and do the peer-to-peers, and those are the things that just have the physicians rolling their eyes. Yeah.
And I can't resist, Jill. My impression from studies is 100,000 nurses are employed doing pre-authorization. 100,000 nurses. So probably 1,000 nurses in
Yeah.
Oregon are doing
Yeah.
pre-authorization on one side or another.
Yeah. And if they're all nurses, I shudder at the cost of that. I mean, hopefully
Yeah.
they're MAs or clerical people too, but yeah. It just yeah, you start to think about, okay, here's the hoops we jump through. We routinely recommend our clients when they're in negotiation with the payers actually have prior auth on the table as a negotiating point. And to your point, John, if you don't frequently overutilize, if you don't stub your toe often, could we please negotiate the need for prior auth, to be way reduced or eliminated in our contract? So that's absolutely a negotiating point as you're thinking about how do we talk to physicians about this, is where, if you start from how can we eliminate their pain points, and how can we eliminate their headaches? That's a big one. So wonderful. All right. Well, I don't want to spend a whole lot more time here, but this is actually sort of where the gold is in their hills. The EHR and the practice management and the EDI costs, I believe there would be some reduction there, some ability to reduce cost. Again, it would be interesting to delve a little deeper and to say, how much are prior auths going to reduce, what's going to be required in terms of coding and documentation and that kind of thing, where that's currently driving up the costs for the technology. Jeff, I saw you pop up there. Did you have a question? And if not, that's okay.
I'll wait till the end.
Okay, very good. I have a couple more slides. I think that we're going to close it in on here. So, Mimi asked me for the top 3 things that I think would be impacted. Obviously, patient payment work and costs would be eliminated both upfront and on the back end. So there's a lot of work that goes into collecting a lot of data and money from patients over the counter upfront, if groups are doing it well, in my humble opinion. That all gets eliminated, so that it frees up a lot in the patient check-in process. And then obviously, again, as we've talked on the back end, we're taking 20 to 25% of the money coming in from a whole bunch of disparate sources and making that a lot easier. As we talked, hopefully referral and prior auth hassle is reduced or eliminated. And then my big question was about the documentation requirements, and probably one of the biggest pain points I hear from physicians is pajama time. And that is all the time they're spending in their pajamas at home in front of their computer charting, finishing their day's work, between 8 p.m. and midnight, a lot of them routinely. So it's not really a great quality of life if you're a physician that doesn't have sort of an automated solution for your documentation. So those are areas that I think could be impacted. And then here I'm going to leave you with just a whole potpourri of questions on the whole thing and what we've talked about. And obviously your subcommittee's organized around what happens financially. So that's going to be the first question on most everybody's mind. And following right along with that is, how does this impact physician business owners? We talked a little bit at the outset, what happens to our workforce in the short and the long term as we think about all of the people that are employed at all of the clinics. John, to your point, if we have 1,000 nurses in Oregon that are doing prior auths and we eliminate that, how do we redeploy those folks in the workforce? One of the big questions I get when I speak with friends in Canada and in other places with universal healthcare is, how timely will the care be? And if we're trying to sell this not only to the healthcare industry, but to the citizens of Oregon, what would happen? Is it going to start to look like Canada? There's a reason why there's a bunch of MRI freestanding facilities on the border between US and Canada, because Canadians can't get an MRI as fast as they want, and they'll pay the cash to get one quicker. So, do we risk setting up a system like that where people are going to drive to Washington and want to go pay for an MRI there? So questions that come up for me. That also begs a question of what happens to the concierge or the cash pay market. As we look at a single payer system, that rarely ever exists in any part of the world. There is always going to be a higher tier of people that will pay cash to get something quicker that they might perceive as better. So we might see, a surge in the growth of the direct primary care or the concierge practices or whatever. Richard, let me pause.
Great job, Jill. I've learned a lot today. You talk about patient collections and how time consuming that is, but there's 2 issues on that slide. It seemed that you're talking about actually the money you do or do not get from patients.
Mm-hmm.
And that's going to be better, obviously, if the patient doesn't have a cost sharing.
Yep.
But then there's also the cost of patient collections on the patient share. But overall, I'm struck that the administrative cost savings can go to single payer. Overall, you've estimated, unless I've got this wrong, at 5 to 10%. I spoke to an administrator of a large physician group, and they said 16% savings. So again, we're not going to argue numbers, but I mean, that's twice as much as you've estimated there. And I'm not saying he or she is right or he or she is wrong, but I'm surprised with all we've talked about and the complexity of billing with hundreds of insurance companies and renegotiating every year, or they should be. The administrative savings are only 5 to 10%. That strikes me as unusually low.
Excellent distinction. Yeah, no, excellent distinction. Talking about the total cost of collections, I'm taking a very narrow definition on that. I think perhaps the gentleman you spoke with had a broader definition. So absolutely, practices would not have a need to renegotiate their insurance contracts every year. There's certainly a cost to that is not factored into my 5 to 10%. So
but if we're trying to hold physicians whole in general,
Mm-hmm.
with universal health plan. We
Yep.
need to be able to extract some administrative savings because it's going to be very expensive to run a universal health plan. So we have to have a pretty good idea that across a physician group who's doing commercial, Medicare, and Medicaid, and
Yep.
and I'm just making it up. Their revenue is $500,000 per physician. I'm not saying what specialty it is, but if we could keep them whole in private practice by paying them $400,000 a year, that
Yep.
would that be workable? Again, we're just talking generalities here, but it is
Yeah.
crucial that we have the big picture on what can we expect from administrative savings from universal health plan, all things considered. Do you have a sense for that?
Yeah, yeah. Well, administrative savings broadly, so
Right.
beyond just the revenue cycle slice that we're talking, yeah, absolutely. So there's that cost of collections, that hard number that we talked about. There would be obviously all of the cost related to renegotiating contracts and updating fee schedules each year for each payer if you're doing it well. There are going to be obviously administrative costs with front office staff that don't have to do, very deep check-ins and data gathering and all of that with patients. There's going to be administrative cost savings with prior auth and referral, depending. Again, it's all about how you're turning that dial. But Richard, to your point, if you're looking at, you're going to pay the physician $400,000, you've got to come up with more than $100,000 in administrative savings for them in order to sell it, right? It's got to be better than their current reality.
Yeah.
Yeah. Yeah. So
But-
you ask a great question. My very true answer to you is I don't know until I have a few more inputs on, what are prior auths going to look like, all of that. As soon as we have more specificity on that, then we could really drill down into what would be a cost savings and get you a much, much more solid number.
Thank you.
Was that spoken like a true auditor? I hedged all my bets on that, didn't I? Awesome. John.
Yeah, I would like, again, to say to my colleagues, I think Jill is being careful here. Particularly, I worked 5 years for Open Notes. I saw the guts of 300 large healthcare organizations. The electronic record system really should be called the electronic billing system. Every institution I ever worked with always made it clear, a medical director, my first priority is to get our doctors trained up and really sophisticated at maximizing the billing system. And the most expensive component of the electronic record system, almost everywhere, I believe, and Richard might weigh in, is the billing system. And Epic is successful. And I had at least 100 doctors, medical directors tell me, we're going to Epic because they have the best billing system. Nobody was really talking about, the healthcare record. It was the billing system. In Boston, Physician Partners, it was public, paid $1 billion for their implementation of Epic across all of their practices. They're a large organization, $1 billion. So the opportunities are there, but you've got to be trusted. You got to be collaborative. Everybody's got to work on all of these issues together with an objective in a fairness in mind.
Yep. Well stated. I like it. Yeah. And I would agree with you, John, that Epic, from what we hear, is, the reason for implementing isn't so much, clinical templates or, driving clinical quality as much as it is. We know the Epic RCM side will work. So, yeah, wonderful. Well, the last three questions, they're bigger ones that I would leave you with as you think about all this is, not so much about the money, but it's all about the money, right? And in the long run, does this make Oregon an attractive place to practice or not? And that answer may differ by subspecialty, again, depending on design. And then, as I come back to my, cost, quality, access, and clinicians, what happens to clinical quality? And what happens to health outcomes at the end of the day? It's all about the patients and the communities. At any rate, I believe that is it for my existential questions. Jeff, did you have a question?
Yes, one question, one comment. The comment is, thank you for the excellent information.
Welcome.
It's appreciated. one of the concerns that we as a committee as a whole have expressed on many occasions is getting the material in advance of the meeting. And you weren't aware of those conversations, but I make this as a general comment. We got the Milliman material that's coming up in advance. It would have been beneficial and provided a more substantive discussion if we had the material in advance.
Got it. I'm happy to share the slides now, so you'll have it.
I appreciate that.
Yeah.
The question is, how many people approximately do we have employed in the administrative side in Oregon under our current system? And approximately how many people would be employed on the administrative side under the proposal?
Excellent question. And that I hate to say it depends. I have an attorney friend who always answers questions with "it depends," and I joke him that he does that. But
and that's why I said estimate.
Yeah, estimate. Yeah, how many? I'd want to start with, how many physicians you have practicing in Oregon. Practice statistics are probably 3 to 4 full-time equivalent employees per physician in order to support them. The highly performing practices, as documented by MGMA, is probably more like 5 or 6. If you ask me the breakdown of clinical versus administrative, you probably have 1 clinical person. In that 3 to 1 ratio, you probably have 2 or 3 clinical people in that 6 to 1 ratio, depending, again, the structure of the practice. And in the after picture, the question is, how many administrative people could you eliminate? I mean, it'd be lovely if you could eliminate 1 FTE, administrative person. That's going to be, you're probably talking about $20 to $25 an hour, so $40,000 to $50,000 of annual costs plus benefits, expenses, all of that. You probably could say, again, these are rough estimates, $65,000 to $75,000 in savings for every 1 FTE that you eliminate in cost. So those are micro, and you could extrapolate over the number of physicians you're talking about in the state. Does that help?
A little bit.
Okay.
But it reinforces, the need. We need a summary that provides all the revenue sources and provides the expenses broken out between admin and, if you will, benefit, so that we can have a substantive discussion about how we're going to make the numbers work. The discussion that the material that you presented today is excellent. No question about that. But it is at I'll call it the rabbit hole area.
Yep.
And it provides any number of rabbit holes for us to go down, which we all enjoy doing.
Yeah. I might suggest.
We need to step back and look at, the big picture, because we're talking billions of dollars here.
Yep.
As you point out. So
yeah. I might suggest the Medical Group Management Association has a tool they call the Data Dive, and that may be a good data set for this group to look into. And I can certainly make introductions there if that's helpful. We know the folks that publish that. Has data from all across the country. So you'd want to, see if you could parse that down at least to maybe West Coast. That would help you. But that will have quite a bit of industry data around cost, around reimbursement. They have quite a few different data sets included in there. So there are multiple different ones of those across the country. That's probably still the best as far as getting private practice data that you could use then to extrapolate throughout Oregon. It also, I believe they do gather data from health system clinics as well. So you might be able to get both. And that may be something to look into if you haven't already.
Thank you.
Absolutely. Thank you. Thank you all for the opportunity to be here. My last slide was, yes, please, let's keep in touch. So feel free, reach out if there are questions. Mimi, I'll get you the slide deck from this morning. And yes, please do let me know. I'll be curious to see how the conversations evolve.
Thank you
so much, Jill.
Thanks so much for joining us, Jill.
Most
That was
welcome.
really informative.
Thank you.
Just wanted to say we're, as you know, very behind, and I'd like to offer either a break right now for 5 minutes or after Milliman, and I think I would defer to Milliman colleagues what your preference is, depending on your own time constraints.
It doesn't matter to me. I'm happy to go right now, or if everyone needs a break, I can go in 5 minutes. Fritz already had to, since we're running a little behind, Fritz already had to leave, so it's just going to be me.
Okay, all right. Well, if we can just take a 5 minute break, and then we'll come right back. How about that? I fear we won't have a break if we don't. So, okay, thank you. I think we're starting. Okay, we're starting now. So,
Okay.
and it looks like you already have a question or comment from John.
Yeah, just Cheryl, I was going to suggest along those lines. I think, Fritz, your comment is relevant. To me, slide 15 is where the big discussion should be, and it's a great summary slide. And so I hope we can spend some significant time on slide 15, and some of the topics you mentioned, Fritz, I think could come later or in a different context. Just my 2 cents.
Thanks for the heads up, John. So, Ken, we'll hand it over to you.
Yeah, and sorry, Fritz was here. He asked a question earlier, but Fritz had to leave another for.
I'm sorry.
So, no, but do we already have another question as well?
Yeah, I was just going to say, to me, it's really important that we get to slide 11. So just to put that out there.
Yeah, in all the slides that it's really that 16 and later, starting with the 5-year and 10-year projections and going on, that I think that's the first half of this presentation that we really need to discuss. I do think it's necessary for I know there's going to be a lot of questions, and I know you had there was a lot of questions, a lot of discussion when we first joined this meeting, and I heard a number of concerns, a number of questions. I do think I should run through about the first 7 or so slide before we start to get into some of the questions, because I think as I was hearing some of those questions, in my mind I was thinking, okay, I actually have answers for a number of these already. So just as a time-saving measure, I would say let me go through at least 7 or so slides, and then we'll start to really open up the discussion. So with that in mind,
that sounds like a good plan. Thanks, Ken.
yeah. So with that in mind, everyone can see my screen. I'm going to skip introductions. My name is Ken Laskowski. I'm a senior consulting actuary with Milliman. I've been here for 20 years. But just to set the stage a little bit, so we have a quick caveat slide. All of this slide is saying is that Fritz and I are qualified to do this analysis, and that this is a very difficult thing to predict. So any exact estimate, we're not going to get this exactly right, which is why we're presenting this in ranges. But you're free to read those caveats on your own time. So as we go to the agenda here, I am going to start with a quick recap, because I think some context here is important. So this is really for us what we consider our 3rd round of results here. So we presented an initial set of results in November, then we refined that in December, and now some more refinements and some additional scenarios that we're presenting in January. So the results are still draft, but they're beginning to congeal. So what's my goal here today to inform you of the current draft projection and answer any questions you may have as you attempt to merge operations with expenditures and with finance. So I do want to disclose here that these presentation materials are the same as our Thursday meeting with the Plan Design and Expenditures Committee. So they're coming a little bit from the perspective of a group that has seen this a few times and will be seeing it for the 3rd time. However, I've refocused some of the discussion here and some of the talking points, and we'll go over that a little bit in the recap. So just so you understand where we're coming from. Getting right into this recap, when we first presented to the Plan Design and Expenditure Committee, We developed an estimate that had a low to high range of about 78 to 90 billion dollars for the cost the cost of the UHP plan, excluding administrative costs. So that's that excluding administrative costs is important because at this point in January is the first time we're introducing administrative cost in for the whole total UHP actuarial estimate. So when we first provided that estimate, it was a 2030 valuation year with 4.7 million enrollees. And then based on some feedback, refinements, new information, dialogue, we revised that estimate to be in December to be a low to high range of 74 billion to 87 billion. Again, at that point, excluding administrative costs. And there's a number of changes made. The major ones that really influenced the cost and had a big change to the cost were the valuation year. So we shifted from that 2030 to 2032 valuation year. The number of enrollees, so that went down. In our initial November estimate, we were including non-residents that work for organ companies, I'm sorry, we're including non-resident workers. And we have an adverse selection population that we project. So to introduce what that is people who will move to Oregon as a result of the UHP. And typically we expect that population to be to have chronic conditions, expensive chronic conditions. So they're a very pricey population. We looked at some additional research on that adverse selection population. We actually lowered the number of people that we assumed would move to Oregon as a result of the UHP to December. And then in December, we also made a number of changes to the cost estimates, just some better base data, a lot of minor adjustments that I won't go through the full list. We removed the non-medical portion of LTSS. So anyone who's getting LTSS, who's eligible for LTSS benefits, receiving LTSS benefits, their medical costs still included. It's just that non-medical portion of LTSS was removed. And we also refined our induced utilization estimate. Again, when we think of induced utilization here, it's not so much utilization increasing as a result of more people getting coverage. It's more utilization increasing because people no longer have to pay. So it's more of if someone went from what we call in the individual market a bronze plan, a 60% actuarial event plan, meaning 60% of their medical costs would typically be covered. If they all of a sudden go to a 100% plan, they're going to by virtue of the fact that they don't have to pay as much, it's all quote unquote free, not actually free. They will attempt to go to the doctor more. They will try to go to the doctor more. We received a lot of comments on that induced utilization. We received a lot of, we looked into capacity issues. So we looked into capacity in terms of PCP availability, PCP number of PCPs, hospital beds, hospital capacity, and we ended up lowering our induced utilization estimates from that first round. So that's how we get from that 78 to 90 billion in 2030 to that 74 to 87 billion in December. So going forward, where does that bring us now? So now we're also, in addition to our low to high range, we're including a best estimate alongside that range. And we've also layered the administrative costs on top of the expenditures to give a full view of the total all-in costs. And further, in addition to that, we've added some additional alternate scenarios. So just to clarify this a little bit, so it's part of our engagement, it's part of our statement of work with you that we won't only provide cost estimates for one plan. We'll have another plan, so a second plan. So when the initial plan is full benefits, full coverage, there's only one place to go for that second plan, and that's to go a little bit leaner. And so we've included this leaner benefit design. And I'll get into the specifics of what exactly is in that leaner benefit design. And then we also, starting in January, are showing results excluding the Medicare eligible population. So that includes both, Medicare fee-for-service, Medicare Advantage, and Medicare dual eligibles, all removed. So again, the idea here isn't that we're recommending any one scenario. It's that we're providing you all the information that we said we would give you, and that you, the board, everyone can make decisions based on that. So again, I think I'll do maybe 2 more slides, and then I can. I see there's one question, but 2 more slides, and I think we can start to pause for questions. There's a couple of things more I want to go over here that there had been questions about. So plan 1. What is this plan 1? What is full benefits? What does that mean? So it's what you think of when you think of the words universal health. There's no cost sharing. No deductibles, no copays, no cost sharing at all. And what we call these PEB plus benefits are included as part of the package. So PEB plus benefits are dental, also covered with no cost sharing, vision, also covered with no cost sharing, fertility, also covered with no cost sharing. And those are the 3 main ones. There's a couple other kind of ancillary smaller benefits. But from a pure what's driving the cost perspective, those are the 3 main aspects of that PEB plus benefit. So our second plan option that we're now introducing here as a frame of reference is what we're calling lean. And lean is a term that it's lean, I guess, relative to the full benefits. But it's not lean from a pure actuarial perspective. Lean, so the difference between the 2 plans is, first of all, we've excluded those PEB plus benefits. So in this second scenario, dental, vision, and fertility, and these other smaller benefits are excluded. They're no longer part of the package. And then we've also introduced this cost sharing. So we put $200 copay in 2032 on ER, and then a few copays, including $5 generic, $75 brand, and $150 specialty on prescription drugs. And to that, we've attached a max out of pocket. And one thing I want to be clear with here is that the idea of this cost sharing applied to this lean plan isn't coming from a perspective of let's do this to collect money to save costs. It's coming from a perspective of steerage. One way to attempt to optimize the UHP is to steer cost towards cheaper services. So when you think of ER and prescription drugs are the two biggest steerage points for plans. So you think of someone who goes to the ER for a cold, attempting to steer them towards the free urgent care instead, because the ER is so expensive. Then when you think of drugs, steering people towards a generic equivalent if it exists, rather than asking for the brand name, which I mean, there's a lot of questions, it's with the formulary, but just choosing this as a point of steerage rather than it's kind of skin in the game aspect. And just want to briefly note here that because this plan is a little leaner, we do adjust the induced utilization down just a hair. But this plan, like I said before, is still a rich plan from an actuarial perspective. It's still about a 98% actuarial value plan. So it's listed as lean, but it's just lean in comparison to the full because PEB plus is excluded. So I believe my next slide is we're going to start to get right into the total numbers. So I think I will.
Excuse me, Ken,
I'll do it.
before you go, what is
Yeah.
98% actuarial? What is 98% actuarial?
Right. That's the great question. So a 90% actuarial value is what portion, if you took the entire population and everyone that had this plan, and 98% of total medical and drug costs are being paid by the plan. So in this case, being paid by the state, and that extra like 1 to 2% is this what's being collected from these copays, these $200 and then these RX copays, and to make so that's what does that make sense? Does that answer your question?
So if we did a PEB plus and multiplied it by 98%, that's what you're describing.
No.
No, okay. Then I do not understand.
Okay. I have a slide that I think one of my next slides I think can help visually kind of walk through it. So it's another way to put it is if someone does go to the ER, the ER is not going to match the 98%. But if someone goes to the ER, and let's say that ER visit is $1,000, technically that person has contributed $200 toward it, and that extra $800, that's what's being paid by the UHP. So that the actuarial value on that one specific visit would be 80%.
So it's a cost shift.
Yes.
Okay. Got it. Thank you.
Mm-hmm. It is putting it is a cost shift, putting a minor cost shift toward the I guess it's not minor when it's in millions, but it is a cost shift toward the Oregon residents or members. I think it's a great time to continue to pause if there's any other questions at this point.
Yeah, Ken, John Santa, just quick clarification. When you say administrative costs, I think you mean payer administrative costs, not the provider administrative costs we've been talking about. Correct?
Yes. Thank you for pointing that out. Yes.
Yeah, because that's important. That's the first time we've seen a number and an estimate, and colleagues, that was a big issue at the task force, and I think these estimates are interesting, but that should be on our plate, and thank you for clarifying that.
Yeah, and that's the first time this is gonna be the first time that PD committee is going to be seeing that is like the administration for Oregon as the single payer, and so this is the first time that we're layering that on. And one of the things I'm going to shift to is really this idea of once I show the admin cost layered on top, I want to keep it's always going to have that payer admin layered on top going forward, just so you see the full number.
Yeah, and just colleagues at the task force, we had quite the back and forth about whether the payer admin cost should be 4% or 6%. And interestingly enough, if my math is kind of correct, these numbers are kind of between 4% and 6%. So anyway, we can talk about those later, but that's an issue.
Yeah, and one thing I'll also caveat with, if you do end up having questions on this administrative piece, so that's we have a separate Millman team who is advising and supporting, excuse me, the operations committee. They developed that estimate. They basically sent me a number and I just put it on top. So if you have detailed questions of that, I am unfortunately not going to really be able to answer a lot of those in depth. Any other questions at this point?
Yeah, so this is Charlie. I've got a question related to the RX steerage fees, I guess was maybe what I'd call them. Is this saying that is the steerage cost for like a specialty drug for all the specialty drugs or only those that have a generic equivalent? Because if it's for all, then it's not really steerage. It's just saying you got to pay more if you're going to do a specialty drug. But if there are, one way to think about it would be we're only going to charge you more if there is a generic available, and you're saying I really want the specialty.
Yeah, so
yeah.
That's a good question. For now,
Is Ken frozen for all of you? He is for me.
Yeah.
Oh,
Just cut out there for a second.
You're back. You're back.
Am I back? Am I back?
Yes.
Yes, you're back.
Now. Yes.
Okay. I heard everything you said. I think it was, what I was going to say, I think it was Jeff earlier that said we're now approaching a point where we have an infinite number of of iterations and an infinite number of possibilities that we can really model. What this is modeling, it is modeling a $5 generic, $75 brand, $5 for all generics, like 3-tier, $75 for all brand, and $150 for all specialty. It is not modeling $150 for specialty drugs that are only specialty and don't have a. Am I saying this right? If it's a specialty drug that does not have a generic equivalent, it is still getting $150. There's still $150 copay applied. So the steerage would still be happening. There are a number of brand drugs and there are some specialty drugs that do have generic equivalents. That is where the steerage would be happening. So in any instance there, we do anticipate steerage, but it is fair to say that, okay, there are some people that need $150 specialty drugs that would be still charged $150 copay, even though there's no generic equivalent. But that's for the simplicity of the modeling, that just to show that is what we have modeled at this point.
Yeah, that makes sense. Thank you.
Again, I think it was more difficult to show results this time because we're starting to just expand scenarios out and out and out. But just so you understand that. I don't see any other hands up at this point. So I am going to get to the brass tacks of it all here, and I'm going to get to our results here. So I don't want to spend too much time on this slide. I want to use this slide to set up for this audience. I want to use this slide to set up just the table of results, because where this slide is coming from is it's that shift of now including the admin and now including this second benefit option. So when we look at this slide, that that 74 to 87 billion, that is excluding admin, payer administrative costs, and there is which leads to an $80.3 billion best estimate of expenditures, and then 85.5 billion once that best estimate once that admin is layered on. And similarly, in that plan 2 with the lean benefits, I'm going to draw your eyes to that 78.5 billion best estimate, including admin and the lean benefit option. So the difference between the two is between the 85.5 and the 78.5 being the removal of that PEP plus and the slightly lower induced utilization and the cost sharing money coming back. Charlie, I see you have a question.
Yeah, so for comparison, what's your estimate of the status quo? That's one question. And another question is, how are you getting these numbers? For example, I guess the more detailed question would be, what fraction of status quo Medicare reimbursement rate are you assuming is being paid by the UHP? Something to that effect.
Yeah, so part of I pulled up our prior month presentation when Jill was talking, because I did hear your question earlier about comparing that to the status quo. So and I'd encourage you to open up the December and the November presentations. They should be online. You should be able to go to the PD&E website and open those up. We did a lot more time. We spent a lot more time comparing the status quo at that point. So I apologize. I don't really have a wasn't planning on initially comparing to the status quo in depth in this meeting because we haven't changed the status quo estimate since then. But here, these numbers, just to lay it out, here, these are the status quo expenditure estimates, and that's 66.6 billion low to 76.2 billion high. And those numbers do not include administrative costs since this is a December number. So that's pure expenditures. This does include dental costs, but dental is the dental costs do increase quite a bit when moving to the UHP. Because dental typically has a lot more cost sharing, and dental is dental and vision are both frequently, and fertility are frequently not offered or not elected, skipped out on. So I think, does that help you answer the first part of your question?
Yeah, that does a good job of answering the first part.
Great. Can you repeat the second part for me?
The second part is, I'm trying to figure out how you're getting the expenditure numbers or cost numbers. And it seems like somewhere in there you have to have an estimate of what fraction of status quo Medicare, or you should be able to find out what fraction of status quo Medicare reimbursement is the reimbursement that you're assuming for the universal health plan.
Yeah, so let me see if I can break that down. We have discussed this at length in the December and November PD&E meetings. So I do recommend going back and viewing that if you haven't had the opportunity. But we've built this projection up from our 2026 baseline. And the 2026 baseline is a starting point based on a number of different sources. Depends on which market. So like Oregon, for example, has publicly available Medicaid expenditures. They're pretty easy to find. So we've used that directly. The most recent year that we have for Medicare, again, there's a number of CMS reports and various reports that come out. We've used that. We've used it for individual market. We're using URT information, and we're using the healthcare supplement blanks, like financial reporting, essentially. So and we also have the APAC as well. So we're using the Oregon All Payer All Claims database. So it depends on the market, but we start with that that baseline level of cost. So we have our baseline population and we have total expenditures in 2026, and then we trend forward from there. So as the question of is, when you think of Medicare, paid out at 100% of Medicare provider reimbursement. We don't really make an assumption on whether or not it's actually 98% versus 99% versus 101%. We have a baseline number and we project that forward. So does that answer your? Does that answer?
No, not really, because somewhere along the way, when you're projecting all these numbers of status quo, you have to say, okay, now we're going to go to the universal health plan, and the universal health plan is going to have one payment rate for everybody. And the question that I have is, what is that payment rate? Say for hospitals, what fraction of what status quo Medicare projections would say is being paid to hospitals per patient or whatever, per kind of visit, compared to what's the UHP going to do? And because you have to make some assumption about what those pay rates are going to be within the universal health plan to get up to costs. And I guess presumably they're all going to be the same for no matter what the patient previous coverage was. But the question is, what is that rate compared to status quo Medicare, to see our physicians going to be doing, our healthcare systems will be doing a whole lot better because we're getting a whole lot more money? Because that's what it looks like to me when I look at these. Way more money is coming into the healthcare systems than with the universal health plan than with the status quo. And why is that? So that's kind of what I'm trying to understand it. And it relates to some other questions I have on slide 11. So yeah.
Yeah, so I think I understand your question a little better now. So once we project out to 2032, we assume that the entire expenditure at 2032 and the entire provider reimbursement essentially will not change. So we've assumed that PEB and OEB are the percent of Medicare reimbursement is about 192%. The rest of the commercial market is about 219%. Medicaid is about 88%. And assuming that Medicare is 100%, that the statewide reimbursement is 115% of Medicare. And so we assume that continues going forward, that 115%. So a follow-up question might be, okay, if you have 80% of the people coming to your facility are Medicaid, are you theoretically all of a sudden going to get a bump up? And if you have, likewise, if you if commercial, if you have primarily a commercial population coming to your hospital, and all of a sudden is your rate coming down? We haven't really. That's one way to look at it. That's kind of dependent on how the state ends up setting the reimbursements, if they set it by area. But we've just for our purposes, we've assumed that 115% statewide continues going forward.
Yeah. Okay. This helps a lot. So where would I find this slide? Is this?
That's in this slide is in both November and December as well.
Okay. Okay. Great. Thank you.
This is slide 29 in December.
For Plan Design and Expenditures Committee.
Yes.
Yeah. Okay. Great. Thank you. And this is for overall. So this doesn't break down hospitals and physician clinics separately. Is that right?
This is overall. We do aggregate that information. We do have that information. We have estimates at each level.
Okay. Okay. That helps a lot. Thank you.
Yep. So to show a little bit more detail into these estimates. Again, going back to that last slide, that are 85.5 billion total UHP all-in cost with full benefits. And then we have the 78.5, which is the total all-in cost with a lean benefit option, which means the range, our low to high range here is the 77 to 94 billion, and on the full, and our low to high range on the lean is the 71 to 86.4 billion. And just to show a little bit, to make sure there's no further questions on this, what's comprising that total UHP cost. This major benefits column is essentially medical and prescription drug benefits. Then we've separated out this PEB plus benefits, that dental, vision, fertility, and sleep studies and the other stuff, which is why the lean benefit has 0 here. And then in cost sharing, we've added these co-pays. So in the lean benefit option, low to high, we assume that the state will be collecting back about 1.1 to 1.3. So whether or not the state is able to have 100% collection, that's another question. But for now, we assume that that's our estimate of what the collection would be at 100% collection would be this 1.1 to 1.3 billion. And then we have layered on the administrative costs. So administrative costs also have a low to high range, 3.6 to 7 billion. Just to note, we have not altered the admin costs between the full and lean benefit scenarios. It's feasible that and realistic that the administrative payer costs are going to increase if there's copay collection, but it's outside of our scope to do multiple administrative cost scenarios. More questions?
John looks like he had his hand up first, so he should go.
Yeah.
Yeah, Ken, I mean, this page is an example of concerns around administrative costs. Notice how the administrative costs almost double in these scenarios between low and high. And so a lot of this, whatever savings or whatever, are gobbled up potentially by administrative costs. Just trying to make that point. I mean,
yeah,
3.6 billion goes to 7. Whoa.
Yeah, and like if you have specific questions on how or why that's happening, I'm happy. If you want to send me emails, I'm happy to get that over to Stephanie Ross and Kate Shadell and the whole administrative cost team to give you a little bit better explanation of what's driving that.
So my I think I'm understanding that this is the administrative costs listed here are the administrative costs on the payer side.
Yeah.
Essentially the state system. And so in your estimates, the 150 or say 110 to 122% of Medicare sort of average payment rate, is that taking into account that there's going to be some provider savings and having the state realize some of those savings in provider offices, or is that not yet taken into account?
Any further savings on top of that are not taken into account.
Okay, that helps. Thanks.
Sure. All right, seeing no other questions.
Jeff's got his hand up.
Oh, okay. Sure.
Thank you. And I think Marianne, you had your hand up also.
Well, I did, and then I took it down, but I'll say real quickly, it is like, I think you offered to send to Mimi or somewhere the question that John kind of raised between the 3.6 and the 7.0 in the plan administrative costs. kind of the justification for, that's a lot of difference, and I'd like to know why.
Sure. I'll also get in touch with that team right after this call this afternoon. I'll let them know that those questions are coming.
Thank you.
And my question is to Ken. First, thank you for the presentation. It's appreciated in its detail, along with the additional questions that have come up. Do you have an estimate, a range, of what current administrative costs are in the system that we currently have?
I believe they do, yes. I don't.
Can you share that with us?
Yeah, I don't have it, but I can have them share it, the current administrative costs.
Thank you.
Yep.
Ken, just wanted to interject here. I think we have about 5 more minutes so that we can allow Echo Northwest to present
Yep.
what they've got. I know that's not enough, but we're clearly not done with this topic anyway, so I'm sure you'll be back.
Yeah, and I think my main idea was to get through at least the first 12 to 14 slides somewhere on here. So, I think that the latter content is more suited towards the PD&E committee anyway. So for now, I'm going to oh, what is happening here? I have if I can get to the next slide.
And before you do, I've got a question, I think, on the very next slide. So yes, this one. So
Yeah.
When I look at this and I see the fraction of total healthcare expenditures, personal healthcare expenditures that are going for Medicare, this would suggest that you're projecting Medicare is going to be something on the order of 39% of all expenditures.
Yes.
If it's removed, or that's how much we remove. But currently, from what I can tell from the numbers, it has been more like 20 to 22% of total expenditures between like 2015 and 2023. And so I'm not quite understanding why has it grown? Why is your estimates saying it's going to grow so much? I guess this just seems like a huge amount of growth compared to what I would have expected.
Right. So there's a couple things influencing that. The major piece that's influencing it is the population projection. So we used again, you can, if you go back to our previous PD&E presentations, you can go look at our sources and exactly what we're using. But we've used a state of Oregon projection on population projection that goes through 2032. I think I actually have it in this presentation on slide I want to say 18 or later, links to it, but it's a population projection on the state of Oregon, and what it shows is a very aging population in Oregon. So the population increase for the Medicare population is going up quite a bit, while the non-Medicare, so 65 and under, really is staying fairly stable and not increasing very much out to 2032. I think it certainly would be a much different, projection if we're projecting for say 2026, if we were. But it is so that's the primary thing that's influencing that is that that population, that aging population.
I mean, still the numbers don't quite make sense to me. I'd have to go through a little bit more, but the aging population seems like it would make it, from basically 900,000 to 1.1 million. So 20% or so. So it should move the 21% average up to maybe 25 or 26%, but not getting close to 39%. So it just seems like that's. And when you remove the Medicare population, are you taking into account that the Medicare then is going to be paying a whole lot less for those people than what the universal health plan would. And therefore, the universal health plan is going to have to pay a whole lot more for everybody else because providers aren't going to accept that. I mean, I'm not sure if you're taking that into account or have you taken that into account?
You know, Ken, if I could, Charlie, you're on the right track. If you go back to Optimus and look at, I think, Table 8, there's a shift in billions of dollars into Medicare and Medicaid because of the normalization of reimbursement. And Optimus emphasized, you guys see how much money is shifting away from the quote commercial to Medicare and Medicaid because their reimbursement rates are going up. I think another major issue is dental's a big deal because a lot of Medicare folks have none. And there would be some very significant dental issues. And Optimus really emphasized that. And that's a $2 to $4 billion issue, I think. So just my 2 cents.
Yeah, if it would help to, I think your latter point was one of the things I was definitely going to say is that and let me actually skip ahead a few slides to help illustrate this point, because I think you understand what this slide is. It's Medicare versus non-Medicare prior to admin, and then if we remove Medicare, we layer on admin. That's the total expected cost. And then this slide is just showing you information that I've already presented, but I just wanted to put it in one nice table so you have one reference point if you need total costs. But I do want to go to this. We have this build up and this comparison to that Optimus 2026 estimate. So if you look at, so Optimus Optimus evaluation year was 2026. And theirs was $55.6 billion, and that includes admin, purely by trending to 23.2. And that's using this trend number. We get up to we add an additional $22 billion to the cost, and then our induced utilization estimate is a little higher than theirs, and then our PED Plus benefits are a little higher. Is a little higher than theirs. Our dental estimate is higher than theirs, and that's driven by age 65 and over is a lot higher dental costs than the under 65 population. And it's also driven by the inclusion of vision and fertility is also probably about, off the top of my head, like $1 billion or so of that difference. And then differences in uninsured, then our inclusion of the anti-selection population, and then that last 1.3 billion is just differences in like a starting point, the information we had, and different assumptions such as trend to get to that 85.5. And then the rest of this graph is just showing, okay, if you shift to the lean benefits, that gets down to the 78.5, and then excluding Medicare would be another 31 billion, depending on which scenario the board chooses. So I think there are a number of questions in there. I maybe answered some of them. I see more hands up. I'll let people re-ask questions.
This is Mary Lou.
Yeah.
Okay. I don't know, maybe the plan design, and I need to go back and watch all of their committee meetings, I guess, but I don't know how much depth anybody's gone into really on the dental stuff. I hear these numbers floating around, et cetera. I think dental is a very different animal, and that Oregon has at least they did have a relatively kind of low number of dentists. We only have one dental school. We make it hard for dentists to come into the state from out of state for their licensing, et cetera. And also their payments, et cetera, that I just don't know, we keep talking about, it gets added in, taken out, whatever, and then looking at it for the Medicare population, I need to know more about, it's not a huge significant, but it's a bigger one. And if we take it away, I'd really like to understand exactly what we're doing with it, but that's all.
Yeah. And it is around 3 to 4 billion just in dental. And dental reimbursements are dental provider reimbursements are a whole different ballgame than medical.
Yeah.
So your point is taken. Yeah.
So I wanted to ask, I think I missed something. Why are we having so many slides on excluding Medicare? Did someone suggest that we were planning a UHP without Medicare? Why all the slides on excluding Medicare?
The idea behind this is to communicate how much of this cost we do think is as a result of the Medicare population, and and skepticism is not right the word, but in the event that a Medicare waiver, quite frankly, has never been attempted. So if the ability to complete that Medicare waiver it doesn't happen, or if the addition of the Medicare population happens, say 2 or 3 years into implementation, if you slow roll out, just to give you options. That's
Well, I think that the better option would be not to exclude Medicare, but to turn it into a state Medicare Advantage plan, still with UHP.
Yeah.
That's my opinion.
And to save time, to me, that's not. I think that's great for you guys to discuss. I'm just trying to provide whatever information I can to help. That's y'all's decision, not mine.
So I've got questions about, have you broken down I guess it would be the status quo projection to what fraction is coming from, say, Medicare, what fraction would be coming from Medicaid in 2032, what fraction is coming from private employers, what fraction is coming from individuals? Is that sort of breakdown available in your analysis? And the reason I'm asking is because from the standpoint of trying to figure out what new revenue we need, probably the most important thing is knowing how much is coming from employers and how much is coming from individuals, and hoping that we can get money from the federal payers, I guess. So is there a breakdown that you've got on that?
We do have a status quo breakdown by market, because that's how we develop it up as well. Yes, I think if you go back to November, I think we have it in there, but if not, we at least have it at 2026. I think we have it in 2032 as well. But if not, I'll go back after this meeting and I'll check.
Hey, Kit.
Great, thank you.
We really need to wrap this up, and I know we have 2 hands up. If I could ask John and Jeff to be really brief, we've got to get to Echo Northwest with the remaining time. And Ken, if you have something you really want to say, to summarize, that'd be great. And I'm sure we'll bring you back.
I'll be really brief. This is the slide I think is key. Again, organizationally, every board member should be able to go through this slide and understand every category, and do so in comparison to Optimus. And this committee's job, I think, is to do that, to go back to this slide, start with Optimus, make sure that all the assumptions that Optimus made are reflected there. And then especially these next 5 categories, starting with induced utilization, are almost $8 billion. Those of us who've been involved in revenue know, our revenue estimate would have to be increased by 50%, and how incredibly difficult that's going to be. How accurate are these? So I would urge we have a session that starts with and goes over this slide, so that we all understand everything in this slide.
I agree.
My follow on to John is a part of that discussion, a breakout of the 21.9 estimate for trend to 32. What's inflation? What's increased population? What are the other factors that go to that 21.9?
It's a big one.
Right.
Yeah. And so yeah, that 21.9 would be both a population, and it would be I believe Optimus used 5.7% trend. So that was taken from their report. So
Is there anything else besides inflation and population growth?
in that trend, no.
Okay, thank you. That makes it a very solid number then.
Mhm.
Maybe.
And the rest of the numbers though are, it's not that just as a point of clarification, it's not that induced utilization is only 1.5 billion. It's our estimate is 1.5 billion higher than Optimus's. Just so that's understood.
Okay.
Understood. All the numbers are estimates.
And realize it seems that from a revenue point of view, we should be using the same population estimates that are being used from a utilization point of view, because that means more taxpayers. There's going to be more taxpayers paying money. And so there's a bunch of things here that need to match up and align, and a lot of work to be done.
I think that's a great point. Yeah. Lining up our population estimates with finance population estimate. I think that's a fair point.
Mhm.
Any other summary words, Ken, before we move to Echo Northwest?
No, it's a very vibrant discussion.
Yeah.
Thanks for having me today.
Yeah.
More
To
than
be
we have the other.
continued, I would say.
Yeah.
Thanks. Thanks, Ken, for sticking with us. I know we were super late. So we'd like to move it to Echo Northwest now for the remaining time.
All right. Right. Are we ready to go and see how fast we can move through this? I think just chatting back and forth with Mimi, we'll move this discussion on the EPT credit to our next meeting. It's probably too much to run through. But I do want to say Charlie put together spent a lot of time and put together a very nice analysis doing two things. I think one, John, trying to bring onto par the way to think about the Medicare population, but then I think further layering on this question around how to think about the credit relative to between wage earners, non-wage earners, and the Medicare population. So with all that, are there any questions that we should be spending a little more time on between now and our next meeting that would enable you to feel comfortable voting on the level of the EPT credit? So I guess that would be my one question to this group is, after you've consumed that, any additional information that would be helpful that we should be working on between now and then? No hands. I guess the only thing I would ask, do we need to spend? Okay, John, go ahead.
Thank all of you so much. I'm ready to vote.
That was my question. I guess.
But I might say, Morgan, we need more time spent on then how to explain this. I mean, I understand it now, but really explaining this to people is tricky.
Yeah. Won't debate that point. Yes, it's the communication and understanding intent and reconciling numbers are all important here. I guess Charlie, go ahead. Since you were the author here, you got probably anything else you want to add to that?
Well, I would just say that another open question that we've not yet begun to talk about, well, two open questions that we just need to put a pin in and say, we got to talk about these. One is the possibility of some sort of a tax on the group between 138% and 200% of federal poverty level.
Mhm.
And then another question is, well, what about raising revenue for the startup and transition costs, and we have not yet begun to do that. So all of those things are just to be determined.
Yeah. As you
It's
know,
gonna take some
with the
time.
conversation you just had, yes, there's kind of, I think the big question is always in this group is, can we first focus on a structure, knowing that we got to move it forward, do the sort of sync up with the actual plan costs and our revenue target. That's work we're doing. I think we're just really trying to make sure that, like, structurally, can we feel like, yeah, we think this is how all the pieces should work, and we can sync it up with these numbers going forward. And there's always going to be some movement. So Charlie, thank you for making sure to sort of remind us of that. Mary Lou.
I guess I would like to go along with whoever it was that said they were ready to vote on the EPT credit. I am ready. I
guess,
have
is it-
I have a suggestion, but I'm also looking at our time and all of the stuff that needs to be done and wondering if we're going to get to, are we going to have another meeting this month? That's a practical kind of question, but
Well, let's take the first question. Is anybody not ready to vote on what I think is a proposal for a 60% EPT credit?
I'm ready to amend it.
Amended.
I
Okay.
would like, just for, I don't know, my gut simplicity, I look between the 45 and the 60 and all of that, I'd like to recommend a 50. It just is easier to explain things to people. It's kind of like the marketing thing of $12.99 versus $13 or something like that. And it's like when you kind of say to people, yeah, you're going to get half of it back rather than 45% or 60% or whatever. People kind of divide in their heads. I just wonder if it makes that much difference, Charlie, because you're the one who kind of put these together, whether we, it seems like it's pretty close to probably what the 45% would be. So that's all.
So I can go along with that. So I was reading a little bit about how did they decide how much the employer should pay and the employee should pay for FICA. As Big said, we don't know really what it should be. How about half? And to me, this is like, okay, yeah, that makes sense. So I can go along with half.
So do you want?
Yeah, I was going to
I
say,
know there's a motion on the table at this point. So who wants to make the motion? And do you want to make that motion, Mary Lou?
I'll make the motion that we establish the EPT credit at 50%.
I'll second it.
Discussion? No discussion? Okay. All in favor with that motion, raise your hand, please. Yeah, either virtual or real. Okay. All opposed, same sign. I know you two voted for it, so I'm gonna say, motion approved.
This really simplifies the spreadsheets going forward. So
yeah.
it-
And Jeff, you asked for kind of a where does everything stand kind of table. It's part of my deck, so you'll get that just as sort of it's always been there in the places, but things have moved on. We've kind of crossed stuff off, and so there is kind of a like, well, what's the rate? How much revenue? What percent of the total? Obviously, that's going to change as we kind of move it, but relative to kind of what our plan target, cost target was, what our revenue replacement target was, at least you'd be able to kind of track all that along. And now with a 50% credit approved. So I'll update that as part of the materials going out.
Was there anything else you wanted to discuss today, Morgan?
I think we can leave the rest of it for our next meeting. I think Charlie summed up kind of where we're headed with the next pieces.
Looks like Richard has his hand up.
yeah, I'd like to, I'm sharing my thing. I just want to make the case that I think there are at least 7 tasks that the Finance and Revenue Committee still needs to complete. And this would argue against a premature closure of the committee. We need to build and refine the personal tax calculator. We need to write scenario descriptions based on that calculator so that people can see what it means for them. Similarly, we have to write those scenario descriptions for small businesses so they get an idea of what the Universal Health Plan means for them. We need to, as Charlie already pointed out, we need to enumerate startup costs and where we're going to raise the revenue. We need to enumerate reserves and where we're going to get the revenue for that. We need to specify the cost in the revenue plan for hospital capital structures and equipment. And then we need to trend our revenue plan to 2032 to match to match what Milliman has presented with us. So we have a lot of work to do in the Finance and Revenue Committee. It seems more than we can accomplish just by March. Thank you.
Thank you for laying that out, Richard. Jeff?
Thank you. Agree with Richard. And then the comment today that was made earlier in our first presentation about reserves versus surplus, that we would need 90 days of reserves. So that gives us a starting point for the number.
Yes. Thanks, Jeff. Charlie?
So I would, I like what Richard presented. I would reorder it a little bit.
Oh.
Yeah, just because a lot of people want that calculator really badly,
Yeah.
but it's like, it's premature to have the calculator
Yeah.
until we have
Right.
a better plan of what we're really going to do. I mean, we can provide a calculator for what's going on right now, but that doesn't mean very much.
No, there's no implicit order. I'm sorry, I should have said that. I would just.
Yeah. I just wanted to point that out. That and I would say it's really important that we include whatever new taxes we might need for startup, or at least a caveat that we have no idea because we haven't yet included them. Something to that effect.
I'd like to correct something I said with Jill Arena. We were talking about administrative savings, and I gave the example of paying doctors $500,000 versus $400,000. I don't know where I was trying to simplify it. I should have said something like $450,000 would have been 10% reduction for administrative costs, and I apologize for not making a very good case for administrative saving. We want to keep positions whole, and I shouldn't have said a 20% reduction. No one's suggesting that there's that much administrative cost to be covered. Sorry about that. Thank you.
Thanks for the correction. So with that, I just wanted to mention the person who was going to provide public comment is not here, so we won't have any verbal public comment today. I do want to acknowledge one written comment we received about concerns for the exodus of providers, particularly physicians, I think, with the universal health plan, and that we need some sort of financial incentive to keep them here. And that actually spoke to Jill Arena's last few questions too. So that definitely is an issue that we need to solve. Not necessarily this committee, but for the whole plan. And then I wanted to end just by addressing the comments and concerns expressed at the beginning of the meeting. Frankly, I was surprised and disappointed with the acrimony of the comments. But I do want to acknowledge that I heard you and that you believe we need to meet longer past March. You would like to meet with both the operations and the plan design committees. You want to figure out more. Well, actually, Richard did a good job of lining out what you want to all work on, so I don't need to repeat that. I would say, first of all, I can't make a unilateral decision on how long we meet and how often, but I can commit to meeting with the staff and the board leadership and the consultants to see what we can do. We do have a hard stop at September because that's when the report is due by the board, and the board obviously needs time to take all of the committee recommendations and merge them together and make sure they fit. They will most likely have to adjust some of those proposals so they actually work together. So I think they need a few months to do that, and then the staff and consultants have to write the report, and so that really backs us up into the spring. So whether we meet more often or a little longer, I don't know, but I will bring that up. I do want to say too that part of my I guess disappointment is due to the fact that I know for a fact the staff, the consultants, and our committee, especially Richard and Charlie, have been working really hard and have come up with a lot of great information to inform our recommendations. So I just want to acknowledge all of your hard work. And then I would say many of you who have been very involved in this committee and care a whole lot about us putting together the best recommendations possible can also think about moving to the transitions committee. So that's another thought that, as Mimi said, they'll begin in April. So I think with that, that's all I wanted to say. Charlie?
Yeah, so it's true that we are obligated, the board is obligated, not us, particularly in this committee, are obligated to provide a report to the legislature in September. But my understanding was that this board, the governance board, was set up to continue. I mean, the reason it was not designed as a task force is because the desire was it was going to continue. And while it continues, the legislature hopefully is going to be considering our report. And I think it would be really useful for some of the committees to be available to analyze for the legislature what's going on with this. And so I would say that our committee, or at least some of us on this committee, should be involved in ongoing things so that we can provide information to the legislature while they're considering the proposal, and also provide information that might come up when there's public feedback, et cetera. So to me, it seems like there's going to still be work to be done, and committees are going to be useful to help the board do that work. So I'll stop there.
Okay, that's an idea I'll bring up with the board leadership when we talk. And by the way, the board leadership happened to be the committee chairs for operations and plan design, which is very convenient too. So we'll talk about that. Jeff?
Agree with Charlie. I did not sense any acrimony in the discussion in the first half an hour. I see vigorous, animated discussion.
Okay, well, I agree to disagree. John?
Yeah, Cheryl, thanks for your comments. Over my life, I think the most effective people have been the folks who can mobilize confrontation and collaboration at the right times. And I'm sorry, but this morning I felt it was time for some confrontation. And I'm still worried about the plan design committee on Thursday and this document that says we've come to agreement on the cost targets when we haven't. But I appreciate your response, and you're signaling that it's time for collaboration. When I listened to Jill Arena's presentation, I see 2 years of working collaboratively with a delivery system that will hopefully trust us, and that we can collaboratively arrive at administrative cost strategies that get rid of useless expenses. And then the board deserves to have an effort that's robust to do that, rather than raising an already incredible tax plan by 50%. That dynamic just has got to be in play, and I don't see it. And I apologize. I have collaborative skills, you know that, and I can marshal them. But I have confrontation skills, and I apologize if that offended anybody. Thanks.
Thanks, John. And I think we all want the same thing. We all want the same goal. I really believe that strongly. And frankly, I'm concerned that if we don't get our work done, we're holding up the other committees. And 2032 sounds like a long time away to me already. And I just don't want to delay it any longer than we absolutely have to. So that's my goal. Charlie?
So I just wanted to say something to one of the points that John made, that we would have to raise taxes, raise 50% more money, which is like almost surely true by 2032. But that doesn't mean we'd have to raise tax rates, because we will have if you actually look at the data from 2019 through 2023, or even 2018 through 2023, the amount of new possible revenue in the increase in payroll and the increase in total income reported on taxes in Oregon was greater than the increase in the healthcare costs that we would have to raise the taxes to replace. And so it's going to be difficult to move this all forward to 2032 with very much confidence. But from what I can see, it's not clear that the increase in potential revenue is going to be smaller than the increase in healthcare expenditures. It's going to be, I would say it's going to be pretty close, and it's going to be a huge amount of uncertainty.
Thanks.
So stop there.
Yeah, and I know we're past time. I just want to give Mimi the floor in case you have anything to say. Happy for you to close if you'd like.
Yeah, thank you. No, I just, the staff will talk with our chair and our consultant groups to talk about next steps for the next meeting. That's all. Thank you.
Speaking of next meeting, second meeting this month.
We will.
That's what we're going to talk about.
Oh, okay, okay. I thought you were talking about past March. Okay, thank you.
Thanks. Thanks, Mimi, and thanks everybody. Have a good rest of the day. Bye-bye. We're adjourned.